Okay, well, we're going to get started. First of all, I want to introduce myself. My name is Kendall Pompey. I am one of the district project managers for BHNNY. I work on the patient activation measure project along with I do CBO engagement. So I'm so glad that we have so many CBOs in the room today. This is hopefully our first of many patient community member navigation training. I do just have to let everybody know that this is being recorded, and it will be used later for WebEx. For folks on the phone, and also folks in the room, if you have staff who wants to do this later, it will be available for viewing. In terms of Project 2DI, if there's anyone in the room or on the line who is actually contracted in doing part of the 2DI project, this is going to count towards some of the performance activities for which you'll receive credit, and it's the first of these four components. The first, the 3 hours of patient navigation, and then for the 1 hour of the alternative EDU, you would receive credit for satisfying those metrics today. In addition to the other two, the health literacy and the cultural competency, those are available on HealthStream now, and they will need to be completed before December 31st of this year. In order to receive credit for fulfilling these metrics, please just make sure that you sign in if you have it. For the folks who are attending via WebEx, you should have received a link through the WebEx so you can attest to the fact that you did participate. Very quickly, I do want to just go over today's training objectives. Hopefully, we're hoping that everyone following this will gain a better understanding of healthcare navigation as a concept, also that you'll gain an understanding of community health workers and their invaluable role in healthcare navigation, and also to participate in discussions regarding community health navigation and what you may be doing or what you're hoping to learn or be a part of or take away from the district initiative throughout our PTS. And these are some of the areas that we're going to focus on for setting of work: emergency departments, primary care, and CBOs, community-based organizations. Also, before we get any further, another housekeeping piece: if anyone needs to use the restrooms are located out of the door, both to the left and the right. Our agenda, I just want to go over who's going to be speaking today. I'm really excited about all the speakers that we have. It's very, very diverse from both the CBO perspective, in addition to the hospital, and actually the work that's being done, the grassroots and out actually in the community. First, we have Tizianos Introduction, and she is from Schenectady Community College. Carla Powers, who is one of our partners and colleagues from the PMO for District and BHNNY. Karen Brooks, who is the case manager here at the hospital. Louisa Mara, who works at St. Catherine's Center for Children. And Bob Cullen, who works for Public Policy Education Fund of New York, and Michael Burgess from Community Caregivers. So with that, here are some guiding questions. I'm going to hand it over to Mark. Thank you all for coming.
Thank you, Anna. Good afternoon. My name is Mark Quayle. Along with Kendall, I help facilitate the 2DI project for the BHNNY office, which is kind of an arm of Albany Med. And we just wanted to give you a couple questions today to think about it. We do have some key speakers speaking today, but I would encourage you, and I'm sure they would too, to be interactive. If you have anything you'd like to raise and questions for us to think about. I don't think navigation is an easy concept to tackle. It crosses many practices, hospitals, right across the continuum, the CBOs and social services. I think we're all trying to figure out what healthcare navigation means, but a couple guiding questions today. What is healthcare, quote-unquote, navigation at the work site? What are the duties that staff perform? I think the key here today, and we'll ask you to kind of tune in with us as we go with this, is it is clinical and non-clinical work. So that's real key here, is that we've had many discussions with organizations, and we find that if there's 10 people in a room, you'll get 12 opinions of what navigation is or isn't. And I think we can't get lost that there's a clinical piece and there's a non-clinical piece to navigation work. I think they're both equally important. How hospitals and practices have changed over time in embracing work tasks that might be outside of a clinical focus. That's getting to those social determinants of health. challenges that staff encounter when assisting patients and community members. What effect has DSRIP had? I don't know if you're all aware of what DSRIP is, Delivery System Reform Incentive Payment Program. It's a whole bunch of Medicaid monies that went into projects trying to transform healthcare, and our project is one of them. We'd be glad to speak to you more. Kendall and I go out to train organizations about 2DI, so we'd be glad to talk to any organizations really if you want to talk further about the project. What more can be done to navigate people to the right level of care, to PCPs in the community? That's a key part of DSRIP. And again, assisting them with the social determinants of health, those are the 80% of the variables that affect someone's health outcomes, their ability to maintain a healthy lifestyle. So we'll talk about those today. And again, these are just kind of the framework for our discussion today. Again, when Kendall and I have talked to organizations, it's always been interesting because you start to talk about what navigation is and you come in with certain assumptions and they kind of blow it out of the water. They have entirely different assumptions of what navigation is. And again, I think we're still really all figuring out how this all fits into the pieces of healthcare transformation. I think it's a key piece. I really feel like, along with the larger concepts of DSRIP, like interoperability and computer systems talking to each other, that kind of thing, getting to a point of clinical integration and care coordination, I think navigation is just as key a concept. So when we've been out talking with people, we've had organizations that they have insurance navigators, they have care navigators, they have community health workers, they have patient navigators, health system navigators, nurse navigators. Again, hopefully we won't get lost in the discussion here, and I think Karen has a good presentation about the nuances of what navigation is and kind of drilling down to the subtleties of that. Here are the social determinants of health. Again, we kind of live and breathe this stuff. We understand the importance of social determinants. We understand the importance of our organizations that are in the community. Several of them are here today, and I really thank you for being here. Personally, I worked for 17 years in child welfare, social services, doing quality improvement work. So I kind of understand that getting into people's homes, working with them at community offices, as opposed to getting to the ED, because we feel like we always say, it's kind of our mantra, when you're in the ED, it's too late. Because of federal laws, you can only recoup so much money in making systems more efficient. So really, it's working with people in the community. And so how do hospitals and practices embrace CBOs, social services, et cetera, to have integrated systems that really make positive change? So if you look at these, again, this is another one of those 10 people in a room, 12 different interpretations of what social determinants are. But it's in the handouts. I think, again, a lot of organizations live and breathe this around helping people with housing, helping people with transportation, helping them with food, a ton of different issues all the way to the right. We have, that's where healthcare is. Healthcare, incredibly important, but it really is 20% of the whole picture of helping an individual with his or her health concerns. We are lucky today to have Tiziana Rota speak, and I'll introduce her. She had her birthday the other day, and I congratulated her on being 29, and I told her, when you get to be my age, the brain goes a little bit, so I can't really do so well in memorizing things, so I will read this real quickly. Dr. Rota is the Project Director for Healthcare Grants at Schenectady County Community College since 2012. She's been responsible for the Health Profession Opportunity Grants, HPOG, sounds great, the largest grant ever awarded to the community college. Under HPOG, is it HPOG or? HPOG. The college is the lead agency for a consortium of 3 community colleges, including Fulton, Montgomery, and SUNY Adirondack, in conjunction with 2 community-based organizations, Albany Community Action Partnership and Schenectady Community Action Program. 2015, they formed the Upstate Partnership for Healthcare Pathways and are operating in 8 counties. Committed to lifelong learning and to serving the needs of the less advantaged, Tiziana has worked for more than 20 years in the field of program in fiscal resource management. In 2014, she developed a course for community health workers. I want to applaud you there. With the assistance of several practitioners and employers, training was launched in January of 2015. In 2016, she spearheaded the development of a behavioral health technician course, so she'll get into those issues, and we do welcome her today. Thank you.
Thank you so very much. I'm quite honored to be here, and I always start my work by asking a set of questions. I don't always find the answers, but I learned something along the journey. So we are part of the Allied Healthcare Training at Schenectady County Community College. But the first question is, who are community health workers? We have a formal definition from the American Public Health Association. Community health workers are frontline public health workers who are trusted members of and or have an unusually close understanding of the community served. This trusting relationship enables community health workers to serve as a liaison, link, intermediary between health, social services, and the community to facilitate access to services and improve the quality and cultural competence of service delivery. Community health workers also build individual and community capacity by increasing health knowledge and self-sufficiency through a range of activities such as outreach, community education, informal counseling, social support, and advocacy. All is very formal, but I would like to dispense from the formality of definition and see if we can identify who they are, what they do, why we need them, and how you can become a community health worker. So for a less formal definition, community health workers are not substitute for clinical staff. Let's get that clear and out of the way. They are crucial adjuncts, an informal bridge for the integration of social and clinical work. They do not take the roles of nurses or other practitioners. They are trusted members of the community, parts of a team, but their formal work is the integration of social and clinical work. But why do we need community health workers? We have a robust health care. We are the country that spends the most money on health care, and yet we don't always get the results that we are looking for. In part, it's because we focus on our own silos. My cardiologist looks at my heart, but the heart operates within a complex body system, and the body lives in a social context exposed to the stressors and life challenges that impact my health. As you pointed out, Mark, the social determinants of health are those structural conditions that impact how we are born, grow, live, work, and age. In general population with poor population with less access to resources, they experience a higher rate of illnesses and death. So why community health workers? There is a large body of evidence from other states who have been using community health workers for quite a while: Texas, Florida, Michigan, Ohio, Connecticut, Massachusetts. They improve outcomes, increase access, lower cost, and are involved as team members in the health reform innovations. These are all key elements of the Medicaid redesign in New York State. They are the liaison with the healthcare system and the consumer community to assist in addressing issues. But what are the issues? They touch the entire range of our lives: social, economic, linguistic, and cultural. Poverty, lack of access, low level of education and health literacy, lack of transportation, personal safety, employment, safe working condition, language barrier, and on and on. So why would a doctor care if a patient lacks transportation? Missing an appointment could lead to severe consequences leading to the ER. Why would an administrator care if a patient has lack of transportation? A missed appointment leaves a gap, and available human and tangible resources are not being utilized to the maximum capacity, leading to a negative ROI, return on investment. It's money, it talks. And community health workers can assist in addressing and working on some of these issues. There are also other specific issues to this emerging profession. Job titles. We've seen the prior slide. We have such a long list of titles: community health advocate, outreach worker, health coach, health navigator, peer counselor, public health aide. And it gets confusing for employers and confusing for people that are trying to apply for a job. In New York State, we do not have a scope of practice for community health workers, unlike other states like Ohio or Massachusetts. And there is no definition of the role of a community health worker at the federal level. Personally, I'm not in favor of a prescriptive role associated with a formal scope of practice, but I would like to advocate for the development of guidelines that would allow the flexibility and diversity of roles while not running into issues with the existing scope of practice, such the 1948 law that established that only nurses can be educators. But the other question is, now that we're seeing some of the issues, what do they do? What can they do? We have some list. It's not a comprehensive one. Care coordination, case management, home-based support, health promotion and coaching, outreach and community mobilizing, system navigation, and community cultural liaison. Here is a list by category. Under care management and case coordination, they would work on individual strength and needs review. Mind you that I'm using the word review and not assessment, again, because under the scope of practice in New York State, assessment can be done only by clinical personnel. They are more like the observe and report link to the individual. Patient and family engagement, addressing basic needs, promoting health literacy, goal setting, coaching and action planning, supportive counseling, coordination, referrals and follow-ups, feedback to medical providers, treatment adherence promotion, and documentation. Under the home-based support category, they would be working on, again, home visiting, patient and family engagement, environmental assessment, promoting health literacy, supportive counseling, coaching on problem solving, action plan implementation, treatment adherence, and documentation. Health promotion and coaching, you see the full list here. I don't need to read it. It's very familiar. And if you start to notice that there are some overlapping categories, you're quite correct. Documentation, treatment adherence and promotion, supportive counseling are some of the most common aspects of the type of work that a community health worker would be conducting. along with outreach and community mobilizing. We have system navigation. Patient navigation is common, but also it's not just for individuals with less resources. I have had the personal experience of helping a well-educated, well-off person trying to understand the system now that mom can no longer take care of herself. What do I do? What are my alternatives? It's not lack of education, it's lack of understanding and system navigation that is pervasive. How do I use, what is consumer direct versus a home health aide? What are the visiting nurses' role? Those are confusing at times, especially at a moment when mom is in the hospital and the doctor says, I'm sorry, but you're going to need some help for your mom. So, and the community and cultural liaison, well, dissemination of material is, again, a critical element of the educational aspect. But I wanted to also point out is how do you become a community health worker? Lack of standardization has created significant areas of opportunities in our region. There are pluses and minuses, you know. When there are no rules, you make your own. Several colleges have launched trainings specific to community-based health cares with different levels of preparation and different emphasis. And SUNY, Schenectady, Hudson Valley, Albany College of Pharmacy and Health Sciences, and Maria College all have this pathway starting from non-credit, short-term, intensive, all the way to a bachelor's degree or a master in public health. But also the teaching methods, like educational institutions, have to be diverse. They have to be addressing the classic didactic lecture style, role-playing, networking, mentored one-on-one learning, and a new twist, apprenticeship. I'll talk about it in a little while. So how do you grow and advance? Well, we talk about pathways, ladders, lattices, roadmaps. In describing a movement to reach an employment goal, work that is financially rewarding, and as one of our students put it, a job that fills the soul. I really love to tell stories. I always refer back to my training as a storyteller, and I would like to share with you 4 instances of people that have gone through some processes. So I would like you to meet Pat. Pat has a high school diploma, worked at a couple of pizza joints. He's outgoing and dependable, but the tips are not enough. And working late at night is not really a suitable life. Pat had seen ads about free healthcare training around town and reached out to the local community action program. It was always a dream for him to work in healthcare, and attending the career readiness course sponsored by a CBO helps strengthen his desire. He's aware of the cultural differences between his community and the medical establishment, but he believes that change is possible. Thanks to our HPA grant, Pat graduates as a certified nurse's aide, and with the help of a community action agency, obtains a full-time job at a local nursing home. The nursing facility is a great source for interaction with colleagues, and Pat develops a reputation for being caring and compassionate, especially with terminally ill patients. CNA jobs are not easy on the body. And the pay, well, is not enough to make ends meet. Pat still relies on food stamp and other portions of public assistance, but a coworker shares with him a program about community health worker. The course is offered in the evening, after work, and it fits his schedule. Pat hesitates because it requires a commitment of 3 months for the academic portion, and then there is an internship, but the course is free, and he hears that there are jobs out there. Pat is not concerned about the academic part. It's easy to read material if you are interested in what you're doing. And the course gives at successful completion 6 credits toward an associate degree in human services at SCCC and at Maria College toward healthcare management. Right after the end of the academic portion, Pat begins his internship. He goes 1 day a week to Catholic Charities and knows that his work makes a difference. After about 4 weeks, Pat impresses his supervisor thanks to his ability to communicate with the language of the people and to engage participants by building trusting relationships. Catholic Charities hires him even before the internship ends. The job is satisfying. In addition, there are always workshops and other trainings that promote knowledge in the medical and social field. However, Pat misses that direct care. The time spent with clients in nursing homes was so good, and he wants to know so much more about the field of medicine. At the HPOC Facebook page, saw an announcement of the partnership between Maria College and SCCC, and anyone who is a CNA from Schenectady County Community College can skip the TEAS, the admission test. From his working connection, he learns that the LPN and community health workers combination are in high demand, and getting a degree would help him get into the dual interdisciplinary field of social work and medicine. The potential for higher pay, well, that doesn't hurt either. Pat is now taking prerequisite courses at SCCC, will start LPN courses at Maria College, will continue to work a flexible schedule at Catholic Charities, and now he supervises his own intern from the same HPOD program he graduated from. Success. Here is Sam. Sam, well, has never been that academically inclined. In high school, she found it boring, irrelevant, and to what her reality was, and at times even dangerous. After a series of life-changing events, she received her equivalency. She's taken care of her grandmothers and other sick relatives, and a pregnant friend tells her about the Willow Project at Albany County. It has always been a hidden desire to work with young parents and young kids. She reaches out to the supervisor of the project, and because of her street savvy, her knowledge of the cultural diversity of the community, along with her resourcefulness, she gets the job. The flexibility of her work time and the challenge of the problem solving while helping others fill the soul, satisfy her. She makes more money than being a caregiver, even if it's never enough. Now she has a family of her own and she needs to move up. She knows that more education is the way to go. Hudson Valley has just started a certificate, Community Health Navigation. She is enrolled and doing well. She will complete in 1 year, and with that certification, she has a chance to move and become a navigator at a local hospital, maybe even Albany Med. I would like you to meet Edie. She finished high school and wished she could have gone to college to become a nurse. She really wanted that, but she had to support herself and bring home a paycheck for her family. She found a job at a little grocery store, a bodega in her neighborhood. As a clerk cashier, she is familiar with the comings and goings of her block, and she is quite personable. People talk to her, share concerns, issues, and older gentlemen start calling her the mayor of Green Street. Edie listens and helps people by connecting needs with resources. One of her regular customers tells her about a new program at a local community center. She shares her experiences and impresses the hiring committee with her mature, compassionate, non-judgmental responses, her in-depth knowledge of the community, and need for advocacy to reduce barriers to help. Edie starts working and finds a way of attending any available workshop and training on diabetes. She has seen the devastating effect firsthand and really would like to work with the elderly. She feels accomplished, but senses that there is a missing piece, the link between diabetes and mental illness. Diabetes is but one piece of the puzzle. The supervisor had given her some brochures, some information, but she hears that SUNY, SCCC, has launched a behavioral health tech course, and the cost is covered by a grant. So she jumps at the opportunity. The additional training adds to her toolbox and of skills and can make her a better, well-rounded link to her community health needs. She plans to continue, become a public health educator by taking online courses at Excelsior College, and if she can get the time, by attending Albany College of Pharmacy and Health Science. Finally, please say hello to Leslie. She does not know what she wants to do. Common at times. She has a GED. She has jumped from job to job, all at a minimum wage. She doesn't want to spend 4 years sitting in a classroom. Her view of education is tinted by her experience in high school. She wants hands-on. At a job fair, she hears about an opportunity. SUNY at SCCC has launched a community health work apprenticeship. She always equated apprenticeship with trades, bricklayer, plumber, construction. There is an application process, and she will have to learn about computer. But SCCC has a PreApprentice Training under the HPOC grant. While it is difficult to find time to go to school, she hopes to make the final cut. She has the ability to relate to diverse people. Her grandmother always called her a girl with big ears, big eyes, and a small mouth, a born listener. The interview process, well, that could be nerve-wracking. But she's admitted to the program, and it will start shortly. Leslie feels she will be a pioneer, one of the first in the area. The program is simple. She will work as an apprentice or in a clerkship position, will earn at a higher rate than before, and her education will be free. No loans, no debts, and a paycheck to boot. She must go to class, but her employer will develop a flexible schedule to meet the Department of Labor and class requirement. She will enjoy full benefit as a full-time employee, and her employer could receive reimbursement for the cost of training her. Once she completes a registered apprenticeship within a year, Her certificate will allow her to work anywhere in the United States, including foreign embassies. What a great way to learn and earn at the same time. The ability to advance is also a significant part of the engagement and retention strategies. Here is a chart that we use to explain to our participants possible areas of advancement. They are going anywhere in between the starting community health worker to the community health manager, and anywhere in between, with growing skills and a range of salary that can improve with each step. These are the 4 examples that I have used: Edie, Pat, Leslie, and I forgot the other one. You will see that they come all from different situations. They are part of a community. They live and breathe what they feel, but they also have some commonalities. What are the characteristics of the community health workers? They are indigenous to the community they serve. They live there. They know it. They bring to the table something that could be taught, but it could take years to learn. They have a strength that most of us do not have because if we do not live within that community. They develop trusting relationship. They share similar life experiences with the people they serve. They are knowledgeable of the cultural tradition and communicate with the language of the people. Mainly, they advocate to build two-way bridges. It's not just one way. It's 2 ways, the needs and the community resources on the one hand, and the medical institutional responses to the need in the other. Building those two-way bridges is essential to the success of any program that will engage community health worker. The success is measured by quality, efficacy, and sustainability. Based on the experience of various programs, Katrina Herman, in an article in Human Resources for Health, outlined 8 key elements of success. Selection and motivation. Community health workers are members of the community in which they work, and they must have a strong motivation to help. Level of education, well, that could be less relevant if you have that desire to assist, to be able to navigate those two-way situations that I described before. Without trust from the community, turnover would be higher, and the outcomes definitely negative. Initial training and selection. Knowledge must be practical in nature, include specific areas of care, chronic diseases, maternal care, etc., and focus on communication and counseling skills. Learning should not stop at the classroom, but be part of a continuum of skill development. Simple guidelines and standardized protocols. To safeguard a baseline of quality of care, the use of protocols such as adherence to a code of ethics will ensure that community health workers do not practice beyond their skills and provide the services that they are expected to support. Supervision and support. It is fundamental that frontline workers have the necessary support to be effective in their work, be allowed to practice self-care, and value their observation and input. Facilitate referrals to health sectors as well as social sectors. For example, being part of a case review. Adequate remuneration and career structure. Turnover is extremely high when the pay scale is below the living wage standard, and there are no opportunities for advancement. Higher pay and $11.75 an hour is not a living wage, along with training, in-service, flex time, formal education pathways, all contributes to the retention of staff. Political support and regulatory framework. By political, I don't mean party politics, but policy making within larger institutions. As I stated before, I advocate for guidelines and an operational framework to foster dynamic responses to community needs and recognition of the contributions that community health workers as a member of the healthcare team bring to the table. Alignment with a broader health system strengthening. Well, we are in the middle of it, aren't we? Now it's time for innovation. Healthcare systems are turning inside out from the old aggregate model to a dispersive model. The critical point will be addressing the social service issues while maintaining the integrity of clinical care. Flexibility and dynamism. We're asking that traditional static structures like hospital, medical practices, adapt to changing need, such as shift in populations due to immigration or displacement, spikes in birth rates, caring for an aging population, and through an integration of services that is unprecedented and yet much needed. For example, the arrival in our area of families from Puerto Rico because of Hurricane Maria. Are we ready for the influx of a new culture, a language that could become a barrier in different lifestyles? Those are some of the questions that we need to kind of look ahead and be able to take a peek about the future. Well, I do not have a crystal ball, but I will attempt to provide some ideas about the future for community health workers. The use of technology. Millions of users have access to cell phone, and their usage can increase the effectiveness of communication for community health workers. You need a ride to the doctor? Let me make a call, and you can set an appointment with Medicab. Obvious, simple, right? That question, why would a doctor care if the client does not have transportation? We can resolve it with just a phone call. Internet access, use of tablets and smartphones to connect, communicate, schedule, inform should be available both to consumers and community health workers. Telemedicine, sharing images over computers, point-of-care support can expedite diagnosis and decisions by a clinical profession of when it is a matter of urgency or if it can wait to the next appointment. How about collection of public health data? Can the notorious PAM surveys be collected and done on a tablet if the proper encryption is provided? You could skip the data entry portion. It would expedite the process. Just a thought. Persuading people to adopt healthier behavior and adherence to treatments are areas open to the use of technology. Sending text messages to patients reminding them to take their medications, accompanied by lifestyle tips, health humor, and even short videos. Or an app as Text for Baby, a free texting service sending messages to pregnant women and new moms on topics such as breastfeeding, immunization, nutrition. What other use can we expect in technology, and how do we protect the privacy and information for our patients? These are issues that we're gonna have to grapple for a while, but we cannot ignore them. Technology and apps, however, would never replace the human contact. They should be aids and not outcomes. Let me add a caution about measurements and analytics. We know how this PPS has required a tremendous amount, and the value-based payment that is coming, tremendous amount of data and analytics. So we should not confuse, however, outputs with outcomes. The CBO, who has distributed 1,000 flyers sharing free HIV/AIDS testing information, has not created an outcome. This is just an output. The outcome will be the number of people who come to the clinic for testing based on the information from the flyer. We can measure the effectiveness of the marketing tool only if there is a relevant outcome. Other medical practices can benefit for the use of the community of workers. Areas of future growth. Behavioral health and any other form of mental impairment should be integrated in the training of community health workers. We offer behavioral health training that is both a stackable credential for community health workers and open to a standalone training for those who plan to work at the entry level in mental health or in substance abuse. Eye care. Early detection of cataracts and other vision impairment can prevent difficult surgery and avoid complications. Well-fitted glasses can increase school performance in children, improve work performance for an adult, and avoid falls for an older person. If you don't see where you're going and you trip, well, that could be a problem. Dental care, we know that nutrition is important, but mastication is the key to our health. A granular educational campaign can assist in prevention and improve outcomes. Bringing people to the dentist. I hate going to the dentist, but it's key to my future and to the way I put food into my system, because food that is not chewed properly can cause problem with my esophagus, my stomach, and everything else. Why do we have so many ads for antacid? Is it because we don't have enough people with proper dental care? I don't know. I'm not a physician. Some of you have probably a much better answer. Pharmacology and medication effectiveness is another area that is starting to take advantage of the skill set of community health workers. Data connected with prescription drug tracks frequency of renewal, but not usage. Assistance with reminders, use of electronic logs, and of community health workers who have trusting, frequent contact with a patient have shown an amazing success in treatment compliance and addressing if the medication really does what it's supposed to be doing. Finally, as educator, we embrace diversity, and each educational institution, community colleges, non-credit, credit-bearing, four-year college, graduate school, we use different models to prepare new professions and to provide them solid foundation for work and room for advancement. The key to our collective success, from recruitment to training to employment, will be related to the strength of the employer collaborations and flexibility in accommodating new approaches in the delivery of health care. As an educator, I believe that knowledge is power, and community health workers have the power to acquire and share knowledge, and yet never lose their community identity. Thank you. Do you have any questions? Sure.
Okay, because this is a new term to me. I am a former case manager. I'm an RN by profession. I'm not college educated, but I've been a nurse for 40 years, and I was a grad of a diploma school back in the day. So I've been one of those people that have done one of those different things, you know, moved from
Exactly.
and got me where I am today. So my question to you is, I agree with a lot of what you've said in terms of what the individual person who is tasked with this particular checklist of job skills requires. So then I would say this person should be a well-connected person in the community. Now that can be a double-edged sword because you can have a person with certain notoriety, but then you want to make sure, I mean, they're held to the same confidential, okay.
Yes.
All right.
And that's why I pointed out the need for protocols.
Okay.
And one of the things that we do in our training is we stress consistently throughout the full 3 months of training the adherence to the code of ethics.
Okay. All right.
The social worker code of ethics is the basis for what we do.
Okay.
Thank
you.
And organizations should have their own guidelines. For example, we have seen community health workers that is helping the single mom with kids, and Christmas time comes around, and she wants to be generous. She wants to give a gift. If the organization has guidelines that says you will not accept not even a pin from your customer, and you can respond by saying, I thank you from the bottom of my heart, but I would get fired, and I think that you care about me, and I care about you, so help me keep my job. Those are some of the guidelines that each individual organization needs to. There are some organizations that says, well, if it is something over $5. For example, the fact that community health workers cannot be doing shopping for somebody. Yes, you want to help. I can bring you to the grocery store, but I will not do the shopping for you because I put myself at a liability and the organization at risk. Home health aides, yes, they can do that. In some cases, you have employers that hire community health workers / home health aides exactly because they can do some medical items that community health workers cannot do. I can show a patient how to put a cuff on the automatic blood pressure little CVS machines, but I cannot do it.
Perform the task.
I cannot perform the task.
Okay.
A home health aide can.
Yeah. Okay.
So we have to be mindful whenever we establish programs that employ community health workers of all of these guidelines, because you want to protect your consumers as much as your employees.
So is there, see, I'm not familiar with the social worker code of ethics, but if I were to,
I can, if you give me your information, I'll be delighted to share it with everybody.
All right. Thank you so much.
My pleasure. Any other questions? I cannot have been so clear that there are questions.
It was a good presentation.
What types of community health workers do most of the hospitals in the area seem to be using? I mean, do you have a sense of like what the industry demand is?
They use it in different ways. From my experience, they use them in the emergency department. They're used in specialty department as a follow-up, for example, for cardiac department, or in the maternity as a way of following somebody when they go home with a baby. New patient, new parents that may or may not know. And the idea of being able to identify potential danger zones like postpartum depression, while they cannot do the assessment, I, as a community health worker, can go back to my nurse and say, you know, Janie has been spending a lot of time crying. And I think that, I'm not sure, but the baby has gained some weight, but, you know, maybe there is something else going on. Raising those red flags, that is one of the key functions, I think, that will help. Because the nurse, navigator, or the visiting nurse does not have the time to go out and observe and see while you're trying to connect somebody with some social needs or transportation or trying to resolve some other issues. There is a movement right now to tend to employ community health workers in community-based organization. Makes all the sense in the world. Community-based organizations are embedded in that community, so they know what they're dealing with. My concern is that it becomes two separate entities, that there is an expectation from the medical profession to have this community organization resolve all of the social issues so that I go back to being a doctor and not having to worry about what the social issues are, because you take care of it. There has to be a continuum of communication, and in my estimation, as I said, I'm looking at things from an outsider looking in. There has to be a continuum of communication, and the integration. The most successful programs have brought community health workers in the team. Connecticut has, and Norwood Hospital has started with about 150 patients that were tasked in this particular unique team, and they have been extremely successful in reducing tremendously the amount of emergency room visits, but also improving the quality of life of the individuals. Well, I thank you so much. If there are no other questions, also from the phone.
You got one more? Can I ask one other question? Are you from France? Are you?
Oh, that's a quiz for
No,
later.
I'm wondering because France has such a different take on healthcare, one of the better on health.
I'm actually from Italy,
Okay.
where community health workers started in the 1920s.
All right.
As part of the push for giving children to the motherland.
Yeah.
And they started as visiting midwives, and they expanded to the entire gamut of social issues, and especially in rural and mountainous areas. So I've been exposed to those concepts, and I'm going, oh, why not?
Exactly. Exactly. Thank you so much.
My pleasure. Thank you for having me. I appreciate it very much.
We will open up in the end for the chat box and for questions through the WebEx. Thank you, Dr. Rota. And I think what touched me was that's exactly what DISRP is trying to solve, is community-based programs, hospitals, having the communication and working people, in the homes. And I think you really had some good points there. One of the topics we did want to discuss today with you is alternatives to ED usage. I think that's interwoven into a lot of the DSRIP work. We have lucky enough to have Karen Brooks here who will be speaking with us. First off, we have Carla Powers, who coordinates a couple of our projects, including the alternatives to alternative to ED usage project, ED care triage. So to give you a little background, you know, this is from a January 14 CMS flyer, but a lot of it hasn't changed. You know, Medicaid beneficiaries use the ED at almost twofold rate higher than the privately insured. Higher utilization may be in part due to unmet health needs and lack of access to appropriate settings. So I think that's what a lot of DSRIP is trying to get at is appropriate levels of care, having more PCPs in the communities where people live. Efforts to reduce ED use should focus not merely reducing the number of ED visits, but also on promoting continuous coverage for eligible individuals, improving access to appropriate care settings, and getting to population health. And again, the strategies that CMS at the federal level and some state levels, including New York, was to attempt to broaden access to primary care, focus on the frequent ED users, and a couple of our projects that Carla coordinates one also was the behavioral health integration. So those are really important projects. Carla does have a bio, and again, I didn't memorize it. She's a project manager at BHNNY, our project team. She oversees two projects, ED care triage and integration of behavioral health and primary care. Prior to DSRIP, there was life before DSRIP. Carla worked for 10 years at Whitney Young as the WIC director, then as the director of school link programs at Whitney. So thank you, Carla, for being with us.
Hello, everyone.
Hello.
Thanks for having me here today. So as Mark told you, I am the project manager for ED Care Triage, and that's the project that I'm going to do an overview today so you can see what we've been doing with our partners through the DSRIP project. And in my previous life in WIC, I did work a lot with community-based organizations, so I do have some understanding of this population and, you know, what they go through and the social determinants of health. And sometimes when you're in a WIC appointment, you want to talk about nutrition and feeding your infant, but if they need housing, that's going to be your priority for the appointment. So really been in that world quite a bit. So to be III, the ED Care Triage project had 5 milestones. The first was to create an ED Care Triage program. The second was to establish partnerships to PCPs. That was really to get NCQA, PCMH certified, expand hours, access. The third is patient navigation, and the fifth was patient engagement. I did intentionally skip 4. There was an optional milestone that we did not do, so I didn't put it on here. And for this presentation, I'm going to focus on the 2 that are highlighted, the ED Care Triage program and the patient navigators. We did complete implementation about 14 months ago in September of last year. And we've been continually working on this project. So the ED Care Triage plan was a 4-pronged approach. The first of these was expansion of access to primary care. So that was really focusing on that second milestone with the PCMH recognition, expanding hours outside, earlier in the morning, later in the evenings, weekend access for working families. The second prong was a focused effort on frequent ED users and at-risk individuals. And that was creating those linkages to services that they need, getting them with the PCP, getting them things that are going to help with their social determinants of health, using risk stratification to prioritize patients. The third was expansion of access to behavioral health services. You know, that's a great need in our community. And the fourth was the delivery of culturally, linguistically, and socially relevant patient education on ED use. So to focus on the patient education piece, which was the 4th bullet on the last slide, we did have a contract metric for our partners in this project. It was metric B11001, and our partners had to provide patient education on appropriate ED use and alternative resources within close proximity. Part of BHNNY's responsibility for that metric, we had to provide a tool to partners that they could either adopt for use or that they could adapt to their own use if they did not want to create their own. And we really did have partners go across the gamut. Some of them just adopted our tool and chose to do patient education with a certain staff person. Others posted it and referenced it. Some added urgent cares near them. So it was, some just created their own. So we did have a variety of different ways of rolling this out. So for the partners, I just explained that. The tool that we selected was we call it the stoplight tool. And I apologize for those of you on the phone. I did not put it on the slide because I didn't think that it would translate well and it would be all stretched out and weird. But for those of you in the room, this is the stoplight tool. If you have not seen it before, a lot of you, if not all of you, have probably seen it. It is a stoplight with red, yellow, and green. The red is if you need you have an emergency and you need to go to the ED right away. And examples of this are trouble breathing, chest pain, bleeding that will not stop. The second light, the yellow light, is go to an urgent care. And that is, you feel like you need help, but you could probably wait. For example, minor injury or urinary tract infection. And the final light, the green light, is I need medical care, but I feel safe to wait a little bit. Says I have a cold or sore throat. And then the idea is that the staff person identified would go through this with the patient, and then they would learn which place was appropriate to receive care. And then a lot of, like I said, a lot of partners did attach, either their hours, their urgent care hours, outside hours, or urgent cares near them in order to reinforce this education. And we did print the tool in poster form, and then we did print it in flyer form. So if anybody is interested in obtaining any of those, I will have them over on the table, or you can reach out to me, and I will be happy to get more for you. Okay, so the second part I was going to focus on are patient navigators, which were one of our milestones for this project. And our subcommittee agreed on some specific responsibilities for patient navigators on work done by Accenture. And these are just a couple of bullet points that I pulled out that I thought would be relevant. Providing those linkages and referrals, coordination, follow-up, coordinate follow-up appointments, whether that be with the PCP or behavioral health provider, really assist the patient in addressing those social determinants of health, linking them with community-based organizations that will help them with those issues. They're going to act as a liaison between the patient, the ED staff, the PCMH staff, the specialist. That's very confusing for us to navigate, and for our patients it can be even more confusing. So having that person and that contact is really helpful. Assisting with medical insurance, that's also another confusing route for most, if not all of us. And then, again, part of this person's role would be to provide education on appropriate ED use, possibly using that tool or another one that I just showed you. And I just wanted to go over some of the work done by Accenture that went into developing the bullet points on the last slide. So several of our partners, I think it might have even been 20 or so, back in the early days of DISRIP, really collaborated together to create what they thought patient navigator support should look like. And so these are the areas that they thought the navigators really could impact: financial, reducing barriers that exist due to financial constraints, logistical. It's going to be transportation or not understanding the appointments, having other priorities, and then the coordination education, reducing barriers due to lack of coordination. Definitely the patient navigator is going to be able to assist with that. And then cultural and linguistic, speaking to them in their language, speaking to them so that they understand why it's important, getting their buy-in. So these are some of the elements that patient navigators can assist staff with, really keeping up to date with the contact information. Demographic information could be useful in creating a relationship with that patient so that they trust you. Who is their PCP? Do they have a PCP? Health literacy, so they can understand their medical conditions. And then just that support system like we've discussed before. And then other barriers that would be to these elements would be financial barriers, we're all aware of these. We're in the community. We know. So I just wanted to put them up there so that you can see all the work that they did over many months. And it's going to sort of lead into Karen, who I believe is coming after me, but each of the hospitals, we're contracted to have a patient navigator in place by September 30th of this year. They each have different models based on their needs and their implementation to meet their unique needs. And I don't want to steal her thunder because she knows way more about it than I do. So I will just leave it there as a brief overview of what we've done with ED Care Triage. And if anyone has any questions, I'd be happy to answer them.
Okay, so now for the last quarter of 2017, all three of those facilities have that. So you'll be able to have reportable data for the first quarter of next year as to how it's impacted.
I don't know if they're required to report specific data, but we certainly gather feedback on it and at our committees. I don't know exactly I don't know that they have to report anything specific. They just needed to have someone in that role.
Okay.
So it sounds like you're going to be getting into this in the next presentation. So are the hospitals, are they hiring these folks directly, or are they contracting out for them? If they're contracting out, is there like...
I can help with that. So I can only speak for Albany Med. I do meet with Saratoga and Columbia regularly. We are hiring them ourselves. We're interviewing the patients, interviewing the staff member to come in. They'll be part of the Benny District program, but they'll be reporting to the case management department, and I will be their supervisor. But we are not contracting out. There will be AMC employees.
This is all very confusing because of the lack of information that we've gotten on the district program. I work in a primary care office that's run by Saratoga Hospital. So I guess maybe it's just how the information has been delivered.
Today or in general?
In general. I'll say in general. You know, we're care managers. We do, obviously, all of these things that you're talking about. We don't have navigators. Now I know you just mentioned that Benny is going to hire.
Well, what it is, it's up to the entity how they want to use that navigation role, and that's what I'm going to talk about in a minute. But so in Albany Medical Center, we have, in addition to our regular case managers and social workers throughout the hospital, including ED, that is part of their role. But we have decided that in order to better meet the needs of our Medicaid patients or those who have underinsurance and no insurance, to make sure they get either into the appropriate health home or Benny, or if it's a St. Peter's attributed person, we are going to have people in our ED that is their role. They'll look to see if a patient has Medicaid or they don't have insurance, and then it will be their responsibility to make sure that they have, the services that they need. If they're inpatient and on the unit, then our case managers and social workers will also be assessing them to see what community benefits they have, such as health home and Benny.
Well, what case managers and social workers? The hospitals?
Our case, I think the problem in healthcare is that the word case manager and care manager is interchangeable depending on what area you're in. So I'm talking right now from an AMC perspective, our case managers.
So from Saratoga Hospital perspective, it would be the case managers within Saratoga?
I can't answer for Saratoga Hospital because they have their own, each hospital has their own unique needs and patient population.
So it's not like you have a specific navigator just to do that?
Yes.
St. Peter's has that too. They have like one C2.
Yes, we have a specific, we are hiring, she didn't start yet. We have someone assuming the role right now until the person starts. But we have identified someone specifically, two people actually, to do that role for us.
So the institution, for example, Benny gives the information to, say, Saratoga Hospital, and then they make a determination on how they have to fulfill this requirement? Is that what you're saying?
Yes. Yes, exactly. Because what works for us, Albany Medical Center, is not going to work for Saratoga Hospital or Columbia University. We try to keep to the same standard, and we all have the same outcomes that we have to meet, like lowering the ED usage and all that. But how we internalize that we can have that individuality.
I think if you contact Dot Jones, she could help you at Saratoga articulate how the project has played out. I'm sure Carla could.
Yeah, Cindy Lasuso. Yeah, Cindy Lasuso at Saratoga, that's who we work with.
Okay.
That's my counterpart over there.
Okay. In one of your slides, I saw that it said, followed by community health workers. I think that we're getting in the nomenclature of navigator, community health worker, what are the differences in roles? Are we handing off people from one person to the next, or are you aiming at creating the one connection that will follow that group of individuals and provide multiple layers of service versus the community health worker goes out, finds the person, and then brings them to the case manager, and then if they don't have insurance, it's handed off to a navigator that then, if you have more social behavioral issues, handed off to a social worker.
So here in Albany Med, we are having the navigator, and we call it an ED patient coordinator. Her official title is she's the link between the outside world and the case managers and social workers here in Albany Medical Center. So just quickly, and then we'll just do my presentation backwards. So when this person comes, is in the emergency room, Kelly, that's the person who's doing it now, when she goes in and she assesses a patient, she'll look to see if the patient meets the criteria either for a health home, which we know or don't know specific is 1, qualifying, or 2, chronic illnesses, having active Medicaid, and not managing well, right? She will assess them for a health home. If the person is appropriate for a health home, she will make a referral to the lead health home, and then the lead health home would disseminate out. If the patient is dual eligible for either, for the PPS at St. Peter's or Benny here at Albany Medical Center, or they live down in Dutchess County, we would find that out, and then she would also make a dual referral to that organization. She then would link up to our case manager and social workers who are in the ED. If the person is in the ED, and say, hey, I just want to let you know that I have made that referral, even though they could see it in the computer. She would link up with them and say, hey, I just want to let you know that Mr. Jones has already connected with Benny and the health home I put my referral out. If the person is being admitted from the ED to the floor, she's then going to go to the floor case manager and social worker and say, hey, I just want to give you a heads up. The patient was referred to Benny. Benny may be reaching out to the patient while they're here in the hospital before the patient goes home. Right now, we're lucky because we have embedded in our emergency room to help us with this new process. We have a representative from Benny who will actually go and talk to that person in that moment at time to help us get our staff up and running, because it's a new process for us. We had to change our computer system. We had to create a tool. You have to educate, 110 employees on it and all that. But the idea is that navigator, in addition to that traditional role of navigation, is going to be the link.
Thank you.
Yeah.
Okay. I don't, just say I'm Mr. Jones and I'm laying in the bed and I have a case manager and a social worker on the floor, and then I have this Benny person come. I'm going to be so confused.
No, you're not, because our job is to make sure you understand that we're starting the discharge process as soon as we can. So when you meet your Benny worker in the hospital, she's going to talk to you about what services she can provide for you at home. The case worker and the case manager and the social worker still are going to do their job to help you navigate through your healthcare trajectory and what your patient services is. It's not one or the other. It's the fact that we need to make sure that before a patient leaves the hospital, if we can get whatever services we can in place that will help them. I don't have a ride to my doctor's office. I don't have insurance. Please help me get my insurance. That's done before the patient leaves the hospital.
Oh, okay. Well, that's what I used to do, is get the transportation. So now I don't have to do that as a...
I think we're trying to make it black and white, and it's not. We have a lot of different roles within an organization when you see as many patients as the size of the Albany Med says. We have our case managers and social workers, and you have to remember, District and Benny are for a very specific population.
Right.
We have a whole slew of other patients and other insurances who still need navigation and coordination and community-based organizations and referrals, and that is continually to be done by the case manager and the social worker.
Right. And I know that Benny works with a certain population, but what I'm saying is, previous to that input, I used to do that.
Right, and
so now that they take that whole slice of it.
they take part of the slice of it.
Okay.
It depends on the patient, and it depends on their insurance and what services they need at that point. Yeah.
All right.
So real time, I'll just say, I work at Albany Family Medicine. We're a primary care doctor's office right across the way. We're very heavily into disrupt at this point, as well as working with Benny on a regular basis. So we have worked with the woman who is actually embedded now at Albany Med.
Barbara Delgado, yeah.
Right, while you're waiting to hire your
Yeah.
navigator. It's been very successful. It's a smooth transition. It's not as complicated as it's being made out to be.
Correct.
It does not change the workflow of the case management social work department here in the hospital, especially on the floors, at all. It is a person who will identify a Medicaid patient who could either benefit from a health home or maybe connect them to primary care, or call us over at primary care and be like, hey, this person's been here 3 times this month. Let's figure out a care plan together. And perhaps then I would refer to Benny, or they would refer to Benny, or but whichever way. It's
And then Benny sends a report out, so we know. So if they made a referral, thank you, if the physician's office made a referral,
right.
then we get a report that says, hey, Benny acted, right, because we check to see if they're already connected to the health center or not. And then we get the report here, and then we know that they're connected there. And then the same way, once we make a referral to Benny, then it goes into HCSNY, and then it goes up to the physician's office, and the referral is made there. So the idea is that we use the term coordinator, some places call it navigator, but her role is specific to Disrupt and Benny and the other CPS. It doesn't negate what the case manager is. And if we have some people who are so complex that on Tuesday, Wednesday, and Thursday, we have called complex case, where we have a multidisciplinary team that the Benny representative come in and sits on that, and it takes the social worker, case manager, the Benny representative, and the CMO to try to get a decision out.
I was just going to say, in the case of disrespect for other people's time, could we just move forward to your presentation?
I'll do whatever you tell me.
Answer some of the questions.
I have the clicker, so, thank Carla for.
Yes, Carla, thank you. Sorry, I took over.
I'm ready for you.
She has materials over here that she had referenced, so please take a look on. After Karen's talk, we'll take a 5-minute break, and then Ben has something to say, but we'll interweave that in here. So, to introduce you halfway through, Karen Brooks has been a nurse for over 36 years. That's probably 14 more than my mom has. She lasted in ICU, so that was very difficult work, but I applaud you for all that time you put into a great profession. With the culmination being awarded her doctorate in nursing in May 2016, her nursing specialization has focused on home care, case management, hospice, and wound care. She's been an education specialist and manager in all those fields. Currently, she is the manager of case management, interim manager of utilization review, interim education specialist, as well as facilitator and educator for the CM/SW department for DISRIC. Wear many hats.
Yep.
And halfway through our presentation.
Yeah, so we did the second half, now we just do the first. So I just want to give you,
Which one, the red one?
so I just want to, what I wanted to talk about, navigating the role of navigator, right? But the idea is, and you can see the conversation that we had, the word navigator is interchangeable, the word case manager, discharge planner. Typically, it all means the same thing, right? I have a patient that is either in a physician's office or in the hospital, and they have to now follow 9 moon directions. So I always like to use myself as an example. So I'm a caregiver at Sandwich Generation. I take care of my mother. She has 25 medications and 5 specialists. She makes every single appointment. She never misses one. Before I leave in the morning, I empty the commode. I put out her drinks. pillbox is not working because we can't remember to lift the lid, so I put everything in cups, change the tray seasonally, now it's a ginger mint, and I go to work, right? The other day I got a phone call on my phone that says, "Hi, Karen Brooks, just want to let you know you missed your eye doctor's appointment. You need to reschedule." It was on the 6th floor. I couldn't get myself there, right? So if we look at the role of a caregiver, and we look at someone who has a chronic illness, 6 physicians and 25 medications. If she was with my sister, instead of being hospitalized 10 times and having 5 falls, she probably would be in a nursing home right now because there's no way that my sister could manage all that. So I want everybody to kind of look at that when we talk about no 2 patients are alike. When we talk about navigation, right, we think of a GPS, right, and there's a lot of car commercials that say it's not the destination, it's the journey. But if I have someone who has a hemoglobin A1C of 500 and they just lost their 3rd toe, the destination is what? Keeping the rest of my toes and managing what I have to do. And for some people, that's a lot. For some people, it's just, I am so anxious and so confused, I can't get out of my own way to get from my front door to the Department of Social Services to apply for that service or that help that I need. And that's one of the things that Betty did for one of our patients. All they did was make reminder calls. All they did was offer her the support to get where she needs. So when we think about navigation, right, it's movement through place. What is the movement that I have to do? What are the directions that I have to follow? What am I supposed to do to get me where I need to be? And remembering it's the patient's goal, right, not our goal, right? My goal is that I'm going to try to get my, not be as floppy and have my hemoglobin A1C. Someone else's goal may be, I don't care what my hemoglobin A1C, but I want my leg to be a certain way, right? So it's what the patient's goal is, and then incorporate what the doctor said. So I just put up some things about navigation, right? Someone in charge of navigating something, guiding, piloting, director finding, right? Those are all the things that we want our navigator or ED patient coordinator to do and help that patient. And the help is going to be as much or as little as the patient needs or wants it to be. It could be actually doing everything for them and making the appointments and doing a follow-up, calling the doctor's office and just saying, did Sharon show up today? We had Barb call us and say, have you seen so-and-so? Because we can't find her. Oh, yeah, she's in the ED. It's her 15th admission right now. Please come over and help us with that. So it's what's steering and how we're going to steer them and where they're going to steer them, all that. So characteristics of a navigator. This is all general, right? Because it's going to depend on, as we just said previously in the last presentation, dependent on the institution and the role and the standards that they have guided on. But if I need to have self-accountability, right? I need to make sure if I'm in the home or if I'm in the ED and I don't have an immediate supervisor following me around, that I'm going to make sure that I hold myself accountable and do what I have to do. The ability to prioritize, right? You could be in the middle of an interview and all of a sudden there's a crisis in the next bay and we need to get someone in there to help support the patient. Communication skills. I say that 100 times a day to the case managers and the social workers. We must have to say the same thing, the same message 17 times, but we have to say it 17 ways because we have to make sure everybody who we're telling understands it. Right? So if I'm having a conversation with a daughter, I may give the message one way, but if I'm having it with a patient, I have to change it to make sure my patient understands what I'm talking about. Knowledge of community resources. Is it, I'm not going to get the job because I don't know every resource, but it's the ability to realize that there are hundreds of resources out there. We just need to make the connection and how we can, and then start building that database. Being a team player, because eventually you're going to be on some kind of team. You're on the patient's team, you're on case management's team, you're a team member in the ED, so being a good team player. The ability to advocate for our patients and those families. And the biggest thing that we talk about, and especially when I talk to Kelly Crone, is my case manager, who's doing that ED coordination right now, is what does the patient want? What do they find? Why didn't they go to the doctor? Find out why. And if it's because, well, you know what? I was 15 minutes late and they yelled at me. Well, why did they yell at you? Were you really 15 minutes late, right? Or they won't let me come back because they don't like me. Well, they have to do more than not like you. They're not allowed not to like you. Calling up the doctor's office and say, Mr. Smith is here again. Can you help us? And figure out why, how can we get him there? Could you give him one more shot? Just give him one more shot. We're referring them to the health home in Benny. We promise he's going to show up this time. And then again, being an active listener. Because we all know sometimes it's not what's said, it's what's not said, right? So those are just some of the characteristics of navigation, a liaison. what have you. So here, as I said to you before, and I'll skip through some of these slides because we talked about it a little bit, but it's always been, navigation's always been a part of healthcare. It's always been a part of case management. We assess the patients from admission, right, for discharge right on admission. The first question we ask is, what are your services do you have in the house? What community resource do you have already? We just want to let you know, you may have home care, you may need this. Can you even return home? Do you have a home to return to? Right? We just had the situation where there was a domestic dispute, the police were called, the husband got all diaphoretic and all upset, and they brought him to the emergency room and got to the floor, and then we're working on the discharge plan, and then we got wife calls and said, don't call me, don't want him back, can't come back, restraining order filed, your problem now. Right? So all these crazy kind of things. And remembering again as the patient's individual. So the idea of the ED patient coordinator is that they will have very specific tasks. Their task right now, but we'll grow it, is to look at the Medicaid and the non-insured patients or underinsured patients and their families to help them through the healthcare process and that healthcare trajectory or the pathway that's set in front of them. I talk fast, so if I talk too fast, let me know. It's a downstate thing. All right? So the idea is that this person, when they come into their role, is that they're going to work with the case manager or social worker. They're going to look at the big four to see if they have Medicaid or no insurance. We're going to look for no primary care. That's a big red flag, right? Are they using the ED as the primary care office? Do they come in for their cold? Do they come in for their asthma? Do they come in for they bump their toe? Are they frequent ED users? In our system, we can look to see how many times a patient's been in the emergency room. So their process will be is to bring the patient up in our computer called Allscripts, go to patient history, see the list of ED visits. Mrs. Jones, you've been here 7 times. That's going to be someone I'm going to flag. If it's Mrs. Smith and she's only been here once, we're still going to see her, but we're going to go in with a different approach, and we're going to go in for a different reason. We're going to interview the patient. We're going to identify social determinants, which we'll talk about in a minute. We're going to begin the referral to the community resources in conjunction with the case manager and social worker. We're going to refer immediately to Betty. We're going to refer immediately to the health home, and then we're going to provide, keeping in that same day, patient education. We have another role, and it's an administrative assistant role. It's below the ED coordinator, and we're growing this right now. She assists with data collection. She assists with any type of ED community care task. She verifies insurance, and then she does other duties as assigned. I'm talking too loud that they're saying, oh, God, get rid of that lady. And then, regardless of who's interviewing the patient, right, is we want to start thinking what could be done different. How can your program, depending on what program you work for, can work for this patient? What can we offer? How can I help them? Why is the patient not able to function or imagine in the community? And remember, it could be as simple as I don't have a car. It could be as I have a car, but I can't drive, and I have 15 appointments that I have to make in the next 3 months. So why aren't they able to manage? Are they following directions? Are the directions on the medication bottle in the language that they speak so they know how to take them? Are the directions where the directions clear? No offense to doctor's offices, don't mean this. But did the patient not ask? But they said, okay, now if you have diarrhea, stop the medication, but if you can resume it in a week if you don't have the diarrhea, and then call me back and let me know how that works, right? And then they go to the pharmacy and it takes 2 pills, may cause stomach issues, right? So they stop it. Right? They don't take the glucophage because the doctor said, if you have diarrhea, you don't have to take it. And I have an appointment in 3 weeks. So when I go back to him, because I don't want to pay another $25 copay, right, or get a bill. And then we ask this, it's in our assessment sheet, regardless of whether it's a case manager, a social worker, or an ED coordinator, do you have a primary care? And if so, when's your last visit and when's your next visit? Oh, yeah, I have primary care. You know how many times you hear, oh, I have primary care. Oh, it's Dr. So-so. Hi, Dr. McCarthy, it's Karen Brooks. We'd like to make an appointment for Mrs. Jones. Mrs. Jones, she hasn't been here for 3 years. Mm-hmm. Right? Oh, what does she want now? Right? So we're going to work on that. If they don't have a primary care MD, immediately to Benny or Health Home. Immediately. Because that's the first thing we're going to try to get help with before they even leave the ED or before they go back to the floor. And then we ask on every patient, what are their current resources and what are their past? And why aren't they using it anymore if they use it? Right? Do they have AV&A? Do they have this? What equipment do they have in the home? And then patient caregiver support and information specific to whatever program that the navigator would be working for. So in our case, this is Albany Medical Center. I'll be here in the ED. If I see you back here again next week, don't forget, you'll see me at the end of your bed within 2 minutes as you walk through the door. Because we see these patients, right? We know that who they are and where they're going. And then social determinants. So this is why we're here, right? The idea of having, whether it's a navigator or a coordinator or a community health worker, is to help us identify the social determinants or anything that could prevent this patient from successfully managing their chronic and or their acute illnesses within the community. Housing, substandard versus homelessness. The amount of homelessness that we get within Albany Medical Center on a daily basis. The shelters are full. Believe it or not, there are some behaviors that they don't find appropriate in shelters, and we have patients who have been banned from every shelter all in Albany County. We sent a patient down to Rockland County, so I don't know if anybody knows that, but it's either Tappan Bridge, because we couldn't get a place to take them, and we had to fight because if they live in Albany County, it's Albany County DSS, it's county money, but we had to get them out. We had a gentleman who took the bus all the way from Long Island up to Albany Med, was found in the train station, and they brought him here. So there was a fight who owns him, because he's really from Long Island, but he was at a shelter locally. So all these kind of things that you don't think about. And do they have medical needs? So if I have someone who's a diabetic, and we went from having an oral medication to an insulin, and now he has to learn how to give his own syringes. And he's on an antibiotic because he had an osteomyelitis, but can I send him to a regular shelter? So one of the things that we did as the Department of Case Management and through Benny, I'll look at Jen because she's my coworker there, through Benny, is that we are trying to build a relationship with the interfaith health partnership. Right? So we will call them listen, I have a patient. Could you take them? Blah, blah, blah. So building those relationships and getting that people on. What is their insurance? Medicare, Medicaid, commercial, and none. When we have a Medicare patient, there's very little that we can do for them, right? Because Medicare doesn't pay for transportation. It only will give you one level of assisted device. So if you're someone who had a stroke, and right now you're using a wheelchair, but you need a walker and then you need a cane, it's only going to pay for one thing. The other day, we said to the wife, please, let us order you the wheelchair. We'll get it through Medicare, but before you go, why don't you go to CVS, and you're going to have to buy the walker, and we'll have our physical therapist show you. Because we couldn't pay for both things. Medicare wouldn't cover both things. Commercial insurances are as individualized as all of us in this room, right? Everybody has their own plan. Everybody's insurance will pay for something differently. And sometimes it's the copayment. Patients don't want to go to the doctor because they have an additional copay. And transportation. As I said, that's our biggest problem with a lot of people. They get in here, but then they can't get out. We work with a lot of local cab companies. We work with Mohawk, Empire, all the different big players that are out there. I have to be honest with you, sometimes we have a little bit of petty cash hidden in my drawer, and we even pay for, the bus ticket back to Square. The other day, we helped someone get back to Jamaica. They were here on a visa. They got sick while they were here. They had emergency Medicaid. Emergency Medicaid only pays for inpatient, so we got them some community resources until we can get them safe to go home. As we said before 1,000 times, and it's worth saying again, primary care provider, access, compliance, incarceration history. The world is a mean place. And unfortunately, when we have a prisoner or someone who's on probation, their family serves along with them. There's a lot of discrimination that goes along with that, so we try to advocate for that population. We have a lot of people who are medically paroled while they're here in the hospital, but then to find them placement or to get them back into the community is difficult. If there's adult protective services involved, that's not a barrier, but we just need to know that because there's a history going on there. Are we going to send this person back to the same situation? If a patient is in the hospital, they're safe. So adult protective services really doesn't, I don't want to say they don't do anything because that sounds mean, but they're not going to do anything because the patient's safe. So we have a working relationship with them. That would be the same thing, is that if a patient comes in and there's suspected abuse by the social worker or the case manager, our ED coordinator would start looking at that, and that's the first call they would make is the adult protective services to say, hey, I just want to let you know. Or they would look in their computer, the bee-boppity-boo, and see that this person is already engaged in Benny or the other programs and say, hey, wait a minute, there is a report of them. So looking for that. Literacy problems, right? Level of reading, the ability to read, the ability to understand. Behavioral and psychosocial issues, that's a big problem. A lot of times people come into the hospital for a medical reason, but their discharge is complicated by their behavioral or psychological issues. We have a patient who acted out in a nursing home. She fell. They don't want to take her back because guess what? She's in your hospital now. Don't have to take her back. So there's a lot of different things that we have to look at. Again, I talked to you about the homeless shelters and different places, and then substance abuse, right? That's another social determinant that is difficult to place a patient where they need to go. So we already talked about this. So the DISRUP is a new role. We created the new role. The ED Patient Care Coordinator will have a navigator, so that's one step below the Patient Care Coordinator. They'll work in tangent with case management and social work. The ED Coordinator, the Community Care Coordinator, will work closely with the physician's offices. When she starts, she'll be calling up, making little arrangements to come over, but she'll making those arrangements and building those relationships. We are building new community partnerships, as I said, with the health homes, with BHNNY, with the interfaith, respite, all those different things. This is what we're doing to create that. New processes for our existing staff. We created an assessment tool, so if they're not sure what the patient is appropriate for, they can go in. They're required to do that tool on everybody. We did our readmission assessment. We changed to a LACE tool, which looks at length of stay, acuity, comorbidities, and emergency use. We use that score as a guide to see if we need to make either a home care or a facility referral, because we look at ED use, but we also look at readmission rate. Was the patient here if the patient was in our hospital within the last 30 days, then we have a trigger. It's another assessment that we do, because reimbursement is attached to that. Your patient was here for CHF, and they left, and 4 days later they came back with CHF symptoms, right? That's going to affect our reimbursement. But if they came back because they fell and got hurt, we still look at that, but it's not going to affect our reimbursement. And then again, I think I said this 1,000 times, the importance of navigation, patient identification for a specific program. What are the services, what are the community organizations, what are the resources that is going to help this patient? That's that person's sole job, right? They don't have to worry about getting doctor's orders, they don't have to worry about utilization review, they don't have to worry about anything. Their sole job is to look at those patients and decide, how can we better help them? Make sure that they're at the right level of care. Are they using the emergency room appropriately? Hey, Mrs. Jones, I know you have asthma, and I know it feels tight to breathe, but let's talk about when you should call 911, when you should go to urgent care, and when you should call for your physician. And maybe if you would have filled your prescription, you might not have had the asthma attack that you just had. Oh, why did you fill it? Oh, you didn't have money. Oh, okay. Well, you didn't have a refill. Did you call the doctor's office? Well, I can't navigate. Press 1, press 2, have the pharmacy call. So let me make that phone call you right now, and let's get it filled down at the inpatient pharmacy and the outpatient pharmacy, and I'll give it to you before you leave. Decrease in hospital patient readmission. We look at the appropriate use of resources, increased support of community resources. So you had asked before about data. We run data on everything. We look at the referrals we send out to whom. We look at LACE tools that were completed and what the patient's scores were. We look at high ED utilizations. We run a report. We look at referrals connected to LACE, referrals connected to BHNNY. So we're constantly looking at our data to make sure that we're meeting the needs of the communities we serve. Yes, I'll stop talking.
Has BHNNY created a tool or used a tool that has collected community resource information?
I can speak only to my experience with them. I know that it's under creation. I know that that's one of our ultimate goals. When we do our big, large BHNNY meetings, that's one of the things that come out. We've created our own, we're kind of building our own resource tool, but if there's a universal tool that's out there, then I don't know, but we could probably...
And who has access to the one that you're using now?
Just our staff in our organization.
Albany Med?
Yeah, Albany Med.
Excellent.
What organization are you with?
Albany Med.
Oh.
I am half-time patient navigator over at PEDS Group.
Oh, okay, all right. So, like I said, this is all groundbreaking, for us. It's building the connection and everything. So I did bring my card, so maybe we can, I don't have 1,000 cards, but I'll give anybody my card who wants it. But let's connect, and I can tell you how. Because we also met with Barb Cataldo from the Children's Health Home.
Yes.
And she comes in and she meets with our pediatric and NICU staff constantly, regularly. So we're, again, making that great.
Karen?
Yeah.
I think Benna had a comment.
Oh, yes, I'm sorry.
From a while back.
I'm Benna Eldridge. Connie and I work for Trinity Alliance in the Capital Region, and we're now community health workers. I don't want to offend anybody, but I have, for many years, having gone from a hospital system to the streets, I feel there's a huge disconnect. You guys are doing a great job, and I can already see it in the South End and Hill and Arbor Hill that people are telling me, I have insurance, you know, I have a primary care doctor. Where the disconnect is exactly on this resource piece. You have resources I would like. You know, I need to make contact with a person who helps you with back medical. I need, you know, there's certain things I still don't have on my.
I agree with you 100%.
I have written a directory. I have, and every day, having done this for 50 years, I have a whole lot of contact with individuals who I know will do the job and do it fast and do it well. I needed a grief counselor. I called her. She was at a conference in Oregon. She texted me back and said we're communicating. You know, as soon as she comes back, she's going to respond to me. These are good people who do great jobs. We need to get together because in the community, we see the people who come back from the hospital systems and they've had really good service. We deal with more people doing the PAMs, meeting them on the street in general work, who don't get to you, who don't go to you, haven't been to a doctor in God knows when. I'm working with a woman now who has 3 children who have never been immunized, never been to a pediatrician. You know, we're seeing people you don't see, and we need to let you know what, you need more connections to Interfaith, which is a great place. I've been working with them for years. There's really good people out there who can help with the ground floor piece, the community at the street level piece that needs to be fixed before people get adequate health care. We need to have communication with you with the pieces that you have that we might access, like help with back medical bills or the prescription, you know, having help people pay for prescription medication. Things like that are medical, but we need that connection too. I think we need to sit down and have a group meeting with, I could probably recommend 10 organizations like Interfaith out there in the community who know their stuff, who are very good at what they do, so that, and maybe we can build something everyone can access online. Because it's really key when you're working with someone and they're not healthy in 99 different ways. And that's what we see when we're living with them. When they go to the hospital, you know, I can't tell you what a great job I think you're doing. But you can only do so much.
Right, and I think that was one of the reasons that Mark and I talked about.
We need to partner.
Because there's one of me and there's all of you, and you know. But I think this is a great forum to have that connection. I think without having this and having me come up and speak, I agree with you 100%. And Jane and I talk about that all the time. How can we get this group together so that we all are on the same page, so that we all know what we're doing, and if everybody can't come, then have at least one representative from all these organizations. And we even talk that with the health homes, because there's so many different, you know, there's so many health homes down there. I mean, again, we get patients from all over the state, you know what I mean? So we're constantly trying to create it, but I definitely think for local, homegrown, I appreciate you saying that, and I think, you know, Mark, now, we're going to make Mark the link, because he's got all of our.
We can even help you fund resources statewide. Out of state. This is what we do too, you know, so.
I think this is a great thing. So maybe out of this could come some kind of meeting where we can all come together and figure out the best way to attack it, you know.
We could even just start something online and everybody contribute. I mean, you know, I just feel that there's a lot of disconnect.
I'm not disagreeing with you at all.
We're both working really hard and we need to
we need to bridge the gap. I agree with you 100%.
Karen has a couple more minutes before she has to leave, so I don't know if there were.
Karen, you know, as you've been implementing this now, the focus is on the benefit, you know, from the ER and with the medical health homes, which are really kind of just in the infancy stages too. How has this worked, you know, structurally? Because really, in prior days, up in, you know, heretofore, really the emphasis is getting somebody out of the ER. If you don't belong here, you know, get out, or we're going to triage you. And even within, you know, outpatient and inpatient settings, it's really canted because of reimbursement and get people out the door. How have you kind of overcome that in terms of slowing things down enough to actually assess and deal and then make the connections and then work with people to get them out in the community. How's that going? And then also, if from a street level, you know, most of us are community-based organizations, we're referring people in. So it's good for us to have this knowledge of taking somebody to the emergency room of like, what are the words you need to say in the ER if we don't think that this stuff is happening. Because, you know, I know you're doing a great job and everything, but the reality of it is, you know, there's always things that fall through the cracks. So, you know, who should we be talking to make sure that, you know, that there's a solid handoff, the baton is passed, or that maybe some critical information about that patient or that consumer is not missed, because you can only gain so much, especially if the person is not really fully conscious or, you know, or has dementia or something like that.
Very poignant in that. So here's my disclaimer. I've only been with Albany Med about a year. No, seriously. But we are working on that. So one of the things is that we have increased the amount of social workers in our emergency room. So we have overlapping shifts. We have them 24 hours. We have a social worker who's on call. There's a new manager of social worker who is working with me. He's been here about 6 months. So he and I both in the infancy of our careers have tried to create that. What I would say is if you have vital information about a patient, you can call and you know that they're on their way to the ED or you're with them at the ED, is ask to speak to the social worker. Because this other navigator role is still very, very much in its infancy. You can call and ask to speak to either the case manager or the social worker in the ED. If for whatever reason they're in a crisis or they can't come to the phone or whatever reason you can't get to them, then I'm telling you that you should be calling the Department of Case Management and asking to speak to a supervisor. You probably will get me, because I'm 2 out of the 3 supervisors, or you'll get Mitch, who is our social worker. And then tell us that information. Say to us, hey, I just want to give you a heads up. There's a patient in the emergency room. This is our concerns. The other thing is that out of this complex case review that we do 3 times a week, we do it Tuesday, Wednesday, Thursday. On Mondays and Fridays, we meet with Dr. McKenna, and we're going to be meeting with Dr. Poise, and we talk to them about these issues. What can we do? Are we to keep the patients longer? Are we to, now granted, there's people who use the emergency rooms, they're non-compliant, they're never going to change, there's nothing to do about it. But there are people who come in who truly have a crisis and we just need to be. So we're keeping them maybe in the emergency room, or we're admitting them into observation to keep an eye on them. If they're inpatient, then it would be, you can call the case management office, because if you don't know what floor they're on, and just say, I need to speak to the case manager who's taking care of Mrs. Jones. Okay, so
I'm just saying, I've called on several patients
so then
that are inpatient and they will not speak with me because of HIPAA.
Okay.
I'm just saying.
Well, I think it depends on the situation. So I think we have a lot of patients, we have a lot of people who call that we do talk to them, but I'm not, you know, if you have a question or you're concerned or you're not getting the answer you need, then reach out to me and I'll see how I can help you. If it's my hospital, if it's another hospital, I can't answer to it, right? The other thing is if the patient is alert or has, is alert, we can say to them, is it okay if we speak to so-and-so, right? There's ways of getting around it. We just have to be creative in doing that. We just had the situation today where a caseworker called, the patient was alert, we went to the patient, we said, Mrs. So-and-so is on the phone, is it all right if we speak to her? And he said, you can only speak to her about what's going on with me right now. You cannot talk to her about anything in my past. And that's what the social worker documents, and that's what the social worker did. So I think there's a lot of room where we have to grow.
Karen, really quick, because I know, and you did a great job. I'm Mickey Jimenez, and I'm a regional director for outpatient substance use disorder program that has huge methadone program, over 600 now, and over 85%.
Yep, one of our biggest barriers.
Right, 85% are on Medicaid. And one of the concerns that I have is what happens off hours, because, you know, Karen may not be there or your case manager during normal hours. And I'll give you a perfect example. Thanksgiving, I actually got a phone call from someone that just knew me and was dealing with a crisis with a loved one, a 22-year-old, go to Albany Med, to the ER. They had Narcan her back. She had overdosed, and they wanted to discharge her. So the family was, wow, no, we want to get her into treatment. I said, well, does she want treatment? I mean, she's got to verbalize this, right? So I did a little education. I had the family actually become the navigator for her.
Yeah.
She slapped her father in the face, you know, and there was a whole big to-do. But staff didn't know that.
So I always, you know, my whole thing is let me try to educate staff, no, if she's asking for treatment, they need to find her. They cannot just discharge her. So I have to kind of intervene, you know, but those resources are not always there.
Well, we changed a little bit, so I don't know if that was Thanksgiving, I don't know why, if you called it. So there's a case manager supervisor on call every night and on the weekends 24 hours a day. So Mitch and I rotate that. So that we also have an on-call social worker who, if you call the operator and say, I need to speak to on-call social worker, you can then say to her, can you please, here's my number, can you please have whoever's on call as your supervisor, call me, I need to speak to them. So I was on call all weekend, I was on call for Thanksgiving. So if you reach out, now, if you can't get anybody then on that holiday or that weekend, then I'm gonna ask that you call me on Monday and say, look, this is my concern. I tried to get this social worker on call. I asked to speak to you. You never called me back. But everybody calls me. The transfer center calls me. Supply chain calls me. You know, I had one social worker who's brand new. She calls me every hour. Then I pay for the patient's medication so she can go home. Yes, I'll find the green rec when I come in. So we are trying to build up that availability so that if staff have a question, now they have a resource. So 24-hour social worker in the ED, on call at 4:30, one of our social workers carries a beeper or their cell phone, and they're available on call, and you get them through the operator. On weekends and holidays, we have staff here who are assigned. They work generally 8 to 4:30. When they leave at 4:30, the on-call social worker takes over. So there's always someone to ask a question. We're working very hard to make sure we can fill that gap, which we know, again, can't talk about the past, but to fill that gap that we know that was there.
And listen, they did a great job. They kept her. But my point was, it shouldn't even have to get to you.
Well,
you know, let's get them more educated.
We got to do that, right?
Yeah.
And that's a slow process, right? And since I've been here as an educator, before I became the manager, I probably oriented, I got to close my eyes to figure it out, maybe 35 new employees. Since I've been the manager, we've hired another 10. Our goal is so that on every floor, and again, only here at Albany Med, that every floor is represented by an RN case manager, an RN utilization nurse, and a social worker, so that we can meet the needs of the patient from all three different angles. So we've had a very large growth. We have a lot of new staff. A lot of our social workers are first and second jobs. Out of college, they all have to have their masters. They all have to be licensed. So we're working with them and helping. And a lot of them, believe it or not, are from the county. So they have to learn Albany Med, and they got to learn Albany County.
Thank you.
Thank you.
I'm just curious. The referrals that originate from the hospitals, I'm referring to the ones for BHNNY and for the health homes, do they require consent?
It's in our general consent.
Okay.
When a patient comes into the hospital, it's part of their general consent, because it's for care and treatment.
Okay.
I mean, like if I go to a nursing home or AV&A, yes, they're part of our general consent. Okay?
Wow, thank you very much.
Thank you.
It's a tight 5 minutes, so we'll be starting again in 4 minutes, 58 seconds.
Okay, everybody, thank you for rejoining us here. We are going to go into our next speaker. Well, we're going to get started here, we seem to be having some technical difficulties. However, our next speaker is going to be Louisa Mara. Louisa is someone that I have a great amount of respect for, and I'm actually honored that I was selected, or actually I said I'm going to introduce her. I had the opportunity to work with Louisa. We did some consumer listening sessions where we got to build in the uninsured and Medicaid beneficiaries to kind of find out what their barriers were to accessing health care and discuss some of those social determinants of health from their point of view on what they needed, and really meeting individuals where they're at and helping them based on something that was said earlier by Karen, that every patient or every person's different and kind of tailoring their care to what they can do. I'm just going to give you her bio real quick, and I do have to read it too. I'm not going to test mine to age like Mark, but I have little people at home, so I'll blame it on them. She is the Associate Executive Director of Homeless Services at St. Catherine Center for Children. She represents the agency and community initiatives related to homelessness. She has over 25 years of working, planning, and directing and supervising staff and services of youth, adults, families experiencing homeless. Again, like I said, personally, I can't say enough about how compassionate and passionate she is about the work that she does. And with that, Louisa, come on up.
Mark is going to help me with clicking because, you know, those are the kinds of things I'm not very good at. So here is, you know, this is our mission statement for St. Catherine's. We provide a comprehensive range of human services designed to offer hope, foster growth, and improve the lives of children and families that we serve. So, you know, who are we? So we're publicly funded, a non-for-profit human service agency, Haven for Hope, offering services, treatment, and education for our communities most at risk, children, individuals, and families in order to heal and preserve family life. Right now, our agency, we offer comprehensive homeless services for families and adults. We have residential services for children 5 to 13, foster care, day treatment, special ed for elementary school, and community-based and prevention services. So I'll talk about what I do. I operate Marillac Homeless Family Program, which serves 24 families in the Capital District. But most recently, in about 2015, we were awarded through the New York State Department of Health an MRT grant, which is called HOPE, Healthy Outcomes Through Supportive Transition. So this is a case management program, but we also have rental subsidies so that we can house our most vulnerable. We focus primarily on homeless and unstably housed in scattered site, but our primary focus is to decrease Medicaid costs. So we're really looking at that highly vulnerable population that is always in the ER, like they've been talking about today. So what happened with Project Hope, we serve Albany and Rensselaer County. And what we found when we were out on the street, because we do street outreach, there were many homeless individuals who had high needs, but their Medicaid cost was not as high, but yet they were very vulnerable. So we applied for a signature grant so that we could capture that population and use that more as prevention. It does not have a housing component, but what we would do through our outreach and engagement is get all the documentation to document a disability and maybe chronic homelessness and refer them to our local Albany coordinated entry, which is the point of entry for vouchers for individuals who have a serious mental illness or substance abuse. So if they were always in the ER, we could go through Project Host, but if they were out on the street all the time, we could move through with them through Project Connect. So when we first started with our MRT grant, I'll be honest, we didn't really know what we were doing. Individuals, it was new to us, but we had a lot of experience in best practice. So what we wanted to do, we didn't really know where we would go to find people. But I knew we had to be on the street to do that. So we needed to go to the places where they would go, and we would provide outreach and engagement right there. So we really wanted to meet people where they're at. We were at soup kitchens, food pantries, and we were always on the street. We're in Washington Park, we're under the bridges. Wherever we could go, wherever we saw people, we would just walk up to them and just start talking to them. We always wanted to know, again, we're client-driven, so for us, it wasn't, I can get you a house and I'm going to find you a doctor. It was, what do you think you need right now and how can we help you do that? And we would do whatever we could to meet that need. We did a lot of navigation with shelters because, as stated earlier, some of them are banned from shelters, and we would go and we would renegotiate and really push, why is this happening? If they had a high medical need and they were being discharged from the hospital, we would connect to medical respite. We would do whatever it took to get people housed, get people connected, and really build trust. For our outreach and engagement, one of the things that we knew were most important was really looking at the research that was out there and what worked. So we connected with a lot of homeless providers in New York City, and we received extensive training in the Housing First model. So with a Housing First model, you do not need to be in recovery or you do not need to engage in treatment to be housed in Albany County under a HUD voucher. We're meeting you where you're at because what we find when people get housed, they may think or they may explore ways of decreasing their use of the substances because they have a safe place to sleep at night. They're not cold. You know, and these are all the things that factor into if people make it or not. Critical time intervention is a case management model that we use. And again, we really needed to be sure that we were totally focused on what the client needed. So if we are in the ER, our focus is what do you want and how can we help you? If you look up at that picture, we're actually enrolling someone in Medicaid. So we would do it from the street. We would refer them to Medicaid. We would then connect with Help Home, get whoever the Help Home provider was going to be, and link them to him. So whatever way we could make that linkage, we would do it. It could be at the park. He at that time was homeless, but wherever they felt comfortable meeting. And this was tricky because when you're working with people who are seriously mentally ill or using substances, you never know what their day is bringing or what that moment is bringing. So what we did, we have a house at 231 Sherman Street in Albany where we could bring them, get them showered, you know, just have them rest a little bit, so when that care coordinator came, they were ready to engage. And again, it's a process, and it takes time, and the first time did not work for him, nor the second or eighth. We just had to keep going and going, but although he wasn't connecting to providers so much, he was connecting to us, and we could be that bridge and really encourage him to try it again. We also supported employment. So if people wanted to work, regardless of where they were with their serious mental illness or substance use, if they told us they wanted to work, we helped them find a job by linking them to the community. Harm reduction. You know, many of our clients, they do not want to, they're not ready. They're not ready to give up their substance, and that's okay, because we're going to work with them. They're not ready to go into treatment, and that's okay. Pam? So with Pam, you know, that helps us measure baseline and where they are at 6 months. It always gives us focus on what case managers could be looking at. And although we know we're not doctors, we're not prescribing, we're not giving advice, but if we know more about a chronic illness, we can provide more effective coaching. So we found that very effective. Increasing income. So many, because of their serious mental illness, they're eligible for Social Security. But it's such a journey to get them through that process. But our staff are all trained to do it. Because once you get income, your housing gets a lot easier for you versus someone that it may always have sanctions because they're not in compliance with DSS. We have a lot of landlords that we provide, you know, we talk about who we serve, so they work with us and they roll with that resistance. And I think also most important, and I shouldn't have left it out, motivational interviewing. It
really, it's a tool that our staff are well-trained in. We have a QA department that provides that oversight, the fidelity, and we have monthly meetings, because if we're not engaging with someone, these are the things we're going to look at as tools on how we can best engage that person and be successful. Most important is client-driven service delivery. If they're not ready, they're not ready. And if we think we have all those answers, they disconnect from us, and they do not want to serve, they do not want to work with us. Strengths, and we do develop independent living plans that we review within our model, and I'll talk a little bit about that, because when I talk about outreach and engagement, what we found is, okay, they have all these needs, but what do we do to have those needs met? So we needed the community to help us out. So, we coordinated with health homes, but, again, that's the whole process. We were getting doctor appointments, and you can call the cab, but we had to go over and make sure they were up, they were somewhat sober, so that they could be seen. If they missed appointments, we would try to get that appointment rescheduled. And one of the other things that we did is we collaborated with Whitney Young so they could bring the mobile clinic, so I could take that opportunity for anyone, anytime. We also collaborated with a committee called PSCC, and don't ask me what it means because I always forget, but it's a committee that is run by Albany County Mental Health, and there are health home providers there, Albany Police, there are housing providers at this table, and they really identify the most vulnerable that are touching on all the systems and how can we best serve them. Albany Med Emergency Room is also there along with St. Peter's. So an example of that is when we were meeting with Philip, and you'll hear more about Philip, there were times we couldn't find him. So we could reach out to Albany PD, the engagement unit, and say, hey, could you help us find Philip? And they would say, you know what, he's on this corner over here. Come on and get him. We developed a relationship with Albany PD where they weren't addressing if there were outstanding warrants or they wanted them to get the help that would make them better. So we all had the same goal. We have now a relationship with emergency rooms. Albany Med is awesome, where they'll call us if one of our clients are there. And they'll call us if they have a client, they see someone coming in, they'll give us a call and say, can you come and help them? So our outreach with clients was so effective, but we knew we had to get that community to wrap around them as well and to instill some hope that they can get better, that they will recover, that we are going to get you housed, and then from there, you're going to grow. Yeah. So within our model, there are different phases, and our big one is outreach and engagement. So we outreach and engage them, but that's to develop the relationship and linkages, and then we move them into that next phase where we help foster that relationship between primary care, health home, judges, anyone that is in your life and your family. So many of our individuals have reconnected with their families, and they're seeing their children again. They're going into, they're trying detox, something they didn't do before. They are going to a primary care doctor. They're doing all the things that we hope will help them become more independent. So during our transfer of care, and that comes up around
our last, right before we're hitting a year. So between each phase, we have a specific focus on what we should be doing. And then at the end of each phase, we meet with all our community providers that surround this individual. So to see what work needs to be done and that we are, we're meeting the needs of that client and we're being client focused. So we want to do a client profile, and it's actually the guy we did our intake with. So before we housed him, he had 160 visits. He lived and slept on the streets of Albany. He had an active warrant. What we learned from him, he was in the hospital for vision and gastro all the time. And we wanted to figure out what is going on with you. But because he appeared to be so intoxicated half the time, he was often being, you know, your stomach's upset from drinking too much, you know, you drink too much, you're not seeing so well. He was hungry. So what we did, we housed him. He was at 160. What we did is we started making sure he ate. And something that we often lose sight of, when you're homeless and on the street, there are only certain places you can go to get food. And if you miss that, you're not going to get food. So if you have to go to a doctor, or if you have to even go to court because there's a warrant, they're thinking about where they're going to get that food. So we started getting him food. We were able to help him navigate through Albany Met, getting full assessments where they found significant cognitive limitations. He had no formal or informal supports. He was very lonely, on the street. No one liked him because he's pretty obnoxious when he's drinking, and he could be pretty assertive with what he wants, but people often looked at that as him being aggressive and could potentially be violent, although he's never had any violence history. History of alcoholism and substance abuse, and also along with his, with everything that he had, he was a victim of domestic violence and had actually been beaten on the street a few times with significant head injury. So it was really hard to figure out where all this behavior was coming from. But just with that alone, we housed him in, if you could look. So this was where we found Philip in 2015. This was him in December of 2015 in his apartment. We connected with CDPHP because of the high need he had, where they were offering in-home services for him. And then what happened in, through his journey, we found with his head injuries, he was having seizures, he was sober, and they were able to see that he really needed a higher level of living. So he is currently right now in a rehabilitation and nursing center, and we continue to see him. And this is him in 2017. Under Project Host, which is the MRT program, this is the data that they've given us since 2015, and I think it's about 18 months of data. Our pre-average inpatient stay decreased across the board. Our average inpatient spending went from 10,000 to 2. Emergency visits, 26.7 down to 8.7, and emergency spending on an average, as you can see, had a significant decrease. Pre-housing ER spending, 43,000 and 181 ER visits, and post-housing ER spending, $325 and 9 ER visits. So we have made some
significant. Our outcomes are awesome. And I was never one for outcomes and understanding it as a CBO, but, it's one thing to see these outcomes and you feel good about that, but if you go to the next slide, I'll go back to the other one. Next one. To the end.
Oh, the end.
Yes. So this is our staff, and I always want to point them out because they go above and beyond. And although they're mindful of, they use their training, we monitor training, they are totally committed to the overall well-being of who we serve. We currently serve, so in host, we have about 35. The data is from that. And in Project Connect, which started a year ago, we have housed 27 that are chronically homeless just in Albany County into permanent supportive housing where they have that support and they have that, and they're reconnecting back to a life that they never saw themselves in. So there's a lot of hope that I want people, it's a lot of work. If you're a CBO, sometimes we'll look at, doctors and we think they know better, and they do, but you know your clients and you advocate for them and you give them what they deserve. So, thank you. Any questions?
Just, what was the source for the outcome data? That was really nice. Is Department of Health tracking these folks as their Medicaid patients and then giving that back to you?
They're not giving it to one, it's each year. It was a pilot project, so it was originally a pilot project for 2 years, and we're coming up on year 4, and now they're going to roll out maybe something more permanent. So all the data.
Very impressive, very impressive.
Thank you.
Do you take interns?
We do. We have SUNY interns, and, it's a great experience for someone that wants to be in the field, and, it's very rewarding for them. And also we have a homeless family program where we also have seen major decrease in ER usage and that language that everyone has been talking about today, just having conversations with people. If your baby has a fever, what are some things that we can do right now? I'm not going to tell you to give them any medicine, but how about we call the doctor and see what they want you to do? And it's practice, right? So they practice.
Thank you. Wonderful. Wonderful.
Thank you.
I just want to say for years I've seen Philip in the community, always struggling, super aggressive, and just thank you and congratulations just on the success of your program. It looks like he's doing really well.
Yeah. And he's for Philip as he really he made life a little tricky for everyone. But he always said to us, and we still go see him, I am 100% grateful. And that's awesome. He's doing very well. He's cooking. He's doing very, very well. And he's off the street. So, thank you.
Lisa, thank you. We're getting close to the end here now, so we're going to try to push through our next 2 presentations. But Lisa, thank you. That was wonderful. Yep, I'll introduce you.
Okay, great.
Okay. Ladies and gentlemen, our next presentation is going to come from Bob Cohen. He is an attorney for over 3 decades with professional experience in advocacy work and legal representation. Currently, he works as the policy director for Citizens Actions of New York, a consumer organization that advocates for social, racial, economic, and environmental justice. Among his previous positions of serving for counsel, he's also worked for the New York State Consumer Protection Board, a state agency. Ladies and gentlemen, Bob Cohen.
Thank you. So I know I'm sort of toward the end of the day, so I'll try to go through this pretty quickly. And obviously, if people have questions, we can do that, or you can stop me at any time. I just want to say that you're all being subjected, I've only been here for about an hour, but many different terms and organizations. So just one point of clarity, I work for Citizen Action, which is an advocacy organization. You might have seen this in the newspapers. We're very political and proudly so on all meanings of that, work on healthcare, education, the state budget, federal budget, et cetera. But the work that I'm describing now is through an affiliated, if people know the term C3, nonprofit that provides services that's affiliated with us called Public Policy and Education Fund. So that's why you have two different organizations mentioned. So one of my many hats that I play at Citizen Action and Public Policy and Education Fund is overseeing our navigation program, which is really what I'm here to talk about today. And I just want to start so there's not confusion. I know navigation has a particular meaning, which was described early in great detail in the healthcare world, and I'm sure in many other worlds. I'm not a social worker, so it could be much broader than I'm aware. But quite frankly, what I'm going to describe is not navigation as you would normally think of that. So if you get confused that I'm using terminology inconsistently with what other people have said, it's because that's the name of the program. I'm not the one who, gave the program its name. It's really enrollment in health coverage and navigation through health plans, not the whole gamut. Okay. So hopefully by the end of this presentation, you'll all understand the background of the state navigator program, and this is again for health coverage. The role of navigators and the benefits of consumers in using one of our navigators, and how to find us. And I was asked to sort of talk about its connection to disrupt and reducing hospital admissions. I'll briefly speak about that, but I'll be honest with you and say it's quite tangential, that connection, and I want to be honest about that. So first of all, what I'm talking about specifically is the Affordable Care Act, and sometimes called Obamacare. Obviously, we don't use that term as much now, and I'm not going to go through it, but what the Affordable Care Act does, but just briefly, really briefly, the focus of the Affordable Care Act, at least when it comes to health coverage, is to get health insurance for people who didn't have it before through the creation of what are known as exchanges. And in New York, we call it the marketplace, or specifically the New York State of Health Marketplace. And essentially, really briefly, what it is health plans enroll people and provide health coverage in many ways very similar to what happened prior to the Affordable Care Act, which was passed, by the way, in 2010. But they're regulated. They have to provide a certain group of benefits, and there are, in New York State, there's a state agency called New York State of Health Marketplace. In other states, there's a federal marketplace, and you probably have heard most about that. It's called healthcare.gov. It serves the states that, for whatever reason, chose not to form their own exchanges. Okay, so as I said, the marketplace or the exchange is called New York State of Health. So let me just ask one question. How many people here have seen in the last 2 weeks commercials for enrollment in New York State of Health on TV? Can you show of hands? Okay, so I think they are doing advertising, not as much as I would like them to do, but it's good to know that some people have seen them. So in New York State, I'm looking at my second bullet, navigators are funded through federal grant funds, and we have to get comprehensive training and criminal background checks. We're subject to HIPAA, privacy requirements, et cetera. My point is that we're very strictly regulated by New York State and federal regulations. There are 526, or at least the last time I was able to see the data, statewide. So what I mean by that is there's 525 specific people, not agencies, who currently enroll 9% of enrollees in New York State of Health. Incidentally, since 2013, there's been 3.6 million enrollments in New York State of Health, and I don't mean 3.6 million people, but that's, if somebody enrolls twice, my understanding is it counts twice. But it's I believe, close to 1 million actual physical human beings that have been enrolled, and the program has been enormously successful in New York. The enrollment, the uninsured rate in New York has gone from 10% to 5%. In that time, we still have more to do, but it's obviously a major accomplishment. The navigation program requires navigators to distribute fair, impartial information about enrollment and the availability of financial assistance. And when we say financial assistance, I mean the specific financial assistance that's available under the Affordable Care Act, not other types of programs. There are two other players in the industry. I hate using the term industry, but I couldn't think of another term for that. One is certified application counselors, which I believe you have at Albany Med, but certainly many hospitals have and other nonprofits. I think really the major difference between certified application counselors, of which there are far, far more than navigators, I think about 5,000-6,000 as I understand, and navigators is that, quite frankly, we receive a grant and they don't. They do it either depending on how you want to look at the goodness of your heart or that you want your patients covered. And there's one other difference which I'll get to later in the presentation, but they do very similar things to brokers and do a lot more enrollment than navigators. There's just more of them. And traditional brokers that are tied to insurance companies, they're often private, but they get subsidized for each enrollment, generally speaking, from insurance companies. So as I say here, only navigators, in my opinion, are both unbiased. We're required to be unbiased, and we can do the full range of enrollment services. And when I talk about bias, I'm not trying to be pejorative, but particularly when it comes to brokers. I mean, there's some wonderful brokers out there. I'm not criticizing, but the reality is if your subsidy comes from Fidelis, I'm not taking a shot against Fidelis, I'm just mentioning them, or CDPHP, then you obviously have a financial incentive to promote that program and no other program. We are explicitly prohibited from promoting one insurance company from another. What we could do without going too much into detail is we can certainly tell you and do, you know, this particular program is the cheapest, this particular program has this doctor in its network, but we cannot say the ultimate conclusion must be the consumer's choice. And that's really what we mean by being unbiased. And also, we have no financial incentive. We do have incentive in the sense that we're going to lose our grant if we don't do enough enrollment, but we have no financial incentive to go to one, to steer somebody to one insurance company rather than another. Yes.
Just another thing to mention, because I mean, we're really focused today more on Medicaid or uninsured, but for those that are on Medicare, there's still a lot of complications. What policy to take, what prescription drug plan to take. So there's a whole nother network out there that maybe you want to put on the slide for the future, and that's the New York State Health Insurance Counseling Program, or HICAP, because all of them are certified by the state. There's a lot of partner organizations, which of Community Service Society, I think, is one, through the MCAP program, and they also do the same thing, unbiased information, help people make a choice, especially like now during open enrollment. And that would be for the Medicare population. You know, you're seeing a lot of folks that are just under Medicare, hopefully,
That's right.
60 to 65 years old.
Yes, there's a lot of, I know I'm saying this to health professionals, which I'm not. I work on many things, but to say the least, there's a lot of fragmentation in the system, and Mark has pointed out one clear thing. We do not enroll people in Medicare. We enroll them in many other things, which I will get to, but not Medicare. So navigators are under the Affordable Care Act. As I said, I think before, have to help consumers make informed decisions on plans they afford and meet their health needs. Again, we tell them the mixture between cost and what programs are available, but they make the decision ultimately. We enroll them in health insurance through New York State of Health, And there's also a small business marketplace, which there's a lot, frankly, less action in. At least we don't deal with it, but there's a separate marketplace under which small businesses can enroll for the purpose of their employees. And this is the list of programs we're enrolling. Qualified health plans is a fancy term for private health insurance for people higher income, although not high income. Medicaid essential plan, I've been told I have about 5 minutes, so I'll go quickly, but these are the programs we enroll consumers in. It's really critical that in addition to enrolling people and giving their choice, we do significant outreach about the marketplace like I'm doing now, but we definitely have played collectively a major role in getting people to come in the door and enroll, and that's why enrollment numbers have gone down. We do educational presentations, as I'm doing now, about health insurance eligibility, plan options, and enrollment. And we refer consumers to a much lesser extent to other agencies, especially when they need to appeal a denial of coverage under the New York State of Health. So it's why use the Navigator? I've already said that, so I'm going to go quickly. Our services are free and unbiased, and we are required and do work on weekends, evenings, etc. So even if we don't have somebody there, we often answer the phone, we have cell phones, et cetera, and get back to people even if we're not necessarily working at that time. Collectively, we speak 43 languages, not everybody in my particular agency, but we have means to refer people to other agencies that speak that particular language. So, as I said in the second bullet, while a navigator's primary role is to help consumers get health insurance, when meeting with consumers, we also help them understand how their plan works and explain basic terms in health coverage. So really getting to, really one of the things Mark asked me to talk about is how it intersects with DSRIP. I think just frankly being there, most of the folks we deal with are uninsured or previously uninsured. They don't know anything about the health system. Often they don't know what a health plan is. They don't know what co-pays are, et cetera, et cetera. And frankly, in many cases, when they enroll, somebody gets them to enroll, they don't know they're supposed to see a doctor. So we do a lot of that basic stuff. We frankly don't have a lot of expertise in all the issues involved with health coverage and healthcare, but the mere fact that we send people, many people, and people who haven't had an appointment with a doctor in 5 years, and urge them to do that, and also, explain to them what they're going to face when they're there, and some of the things they should be telling their doctor, I think is really the main intersection with DSRIP and the goals of DSRIP specifically. So I should also say that for people who have had some familiarity with the program, the biggest thing that's new this year is that New York State of Health, and specifically the health department, is really everywhere on the web, has a new provider and health plan lookup tool that allows consumers to search which doctors and hospitals are in each plan's network. This is obviously critically important. People might not have health coverage, or they may be switching to health coverage, but they like their doctor, so they can look this plan up, use this tool very easily to look up their doctor, the hospital they're accustomed to going to. So I would just urge people to try it out. It's really very user-friendly. It's been around for a few months now.
So this is for 2017 or for 2018?
It's what for 2017?
Okay.
I'm sorry.
The providers that are participating are for 2017 or 18?
It's currently online.
Okay.
And it's ever-changing. There's requirements that providers update their status every couple of weeks. So, and there's even a means for consumers to tell them that there's a mistake. So I'm going to go quickly. I've been told I have only a minute, so I'll just say that we do
start thanking people.
What?
So start thanking people.
Right. So I'm just saying we do some referrals. but frankly, it's mostly focused on health insurance. I'm going to skip through this and just say that the one other thing that I wanted to point out is that there is a related program called Community Health Advocates. If a consumer has problems with their health coverage, once they get it, and health insurance, once they get it, they can help consumers with billing problems, they can help them, deal with their doctor, et cetera. So I think it's a very vital resource, so I would urge you to refer people if it's appropriate.
Okay.
And
Put that number again, is the 188?
I was told you all are getting this PowerPoint, but
Okay.
it's 1-888-614-5400.
Okay.
We'll send a slide.
Oh, okay.
I think that's really all I have time for.
Thank you, Bob. I'm sorry about the time.
Sure, no problem at all.
We both have business cards up here if you're interested.
Yeah, with our phone, our particular phone number.
Were there the chat box is also available if there was any questions, so please feel free to utilize that for the folks online. And next, we have Michael Burgess, another one of our partners who has been instrumental in bringing back feedback to our PPS, and we appreciate all of his input. It's always very valuable. Mr. Burgess is a consultant with Community Caregivers, which is a local not-for-profit volunteer neighborhood Helping Neighbors agency. He spent over 40 years working in the aging and human services field. He served as executive director for statewide Senior Action Council, where he started the Patient Rights Project. He also served as the executive director for the New York State Alliance of Retired Americans, representing union and community retirees, and was appointed by Governor Spitzer's and Patterson's to serve as director of New York State Office of Aging from 2007 to 2010. Welcome, Michael.
Thank you.
Thank you.
So, am I up here now? I just need to push this button.
That's all you got to do.
Well, the good news is you're only 15 minutes from the weekend, okay? So, I've heard a lot of what was mentioned today, and I'm not going to go through a lot of the PowerPoint because a lot of it is similar on the issue of patient navigation to a lot of what you heard before. You know all of this stuff about all the changes that are going on in healthcare and the trends. It's a revolution, I'm saying, and what's going on. And I'll say it this way. 30 years ago, when I was at Statewide Senior Action Council, we got a $180,000 grant when diagnostic-related groups were put into Medicare, which meant that hospitals were paid on the basis of illness. We got the grant because people were being sent home quicker and sicker, as we said, because they didn't get any other than, they could get home care, they could do it on their own. There was really the kind of follow-up care resulted in some of the things that Marcus mentioned, people slipping through the cracks, and we still hear it. I mean, people going home in the middle of the night. I would like to think that the result of what DISRIP does is that it revolutionizes care transitions and that we end up finally solving this whole thing of people not being, kind of on their own, that there is a process for them for their future, that they don't get readmitted. And I really want to stress that the Aging Network, which I've worked in, and some of us here, I'm working with Community Caregivers, which has like 100 to 150 volunteers out there in the community who are helping people stay at home, driving them to the doctor, shopping, friendly visits, and those types of things. And the Aging Network, what I want to give you a picture of is that while all this is going on in healthcare, every county has an office for the aging. Every office for the aging has a caregiver support program. Everyone has a HICAP, insurance counseling, that Marcus just mentioned. There is this movement to keep people out of the hospital, but there is a bigger movement in the aging field to allow people to live their life in the community that they choose. So you see this mushrooming, Sunday's Times Union, the real estate section, the front cover, the village movement, seniors creating self-help villages through things like community caregivers. And patient navigators are part of that. The CARE Act, this was something AARP helped to pass, requiring hospitals as of a year ago to allow the designation of a caregiver and that the caregiver has to be trained when you send them home from the hospital. If you're going to require them to do certain functions, which are non-medical usually, then they have to be trained in those functions. Okay, we know all this stuff. I'm really moving ahead here. You've heard of New York Connects, which is through the Office for the Aging. In every county, a hotline for long-term care assistance for people. And that's for people who are younger who call up and say, my mother can't live at home anymore. What do? I don't know anything. I don't even live there anymore. I live in California. I'm going to come back to that slide in a minute. So I wanted to just describe to you that all of these things that are going on, let me mention a couple things. Reserve, R-E-S-E-R-V-E, Inc.org. That's a program of retirees who are doing volunteer work on stipends. Not up here yet, but in New York City. I've been pushing to get it up here. But in New York City, those volunteers who are retired from professional work, maybe nurses, they're working in a hospital in a dementia coaching project, okay? So we're trying to unleash the use of volunteers. And unfortunately, I shouldn't put it this way, but I think most of what we heard today, which is fine, was about people being employed in the hospital. And what I'm trying to, about navigators. But I think that, question? No.
Thought I'd mention that we have something similar for linking people to volunteer opportunities called Serve Albany.
Mm-hmm. Okay, we want to know more about that. I saw that, and we're going to. I think that the whole idea, when you have this huge wave of baby boomers retiring, many of us, like me, who worked in State Office for the Aging, we have nurses at Community Caregivers who are working with us. We have students also from Albany Med who get their service learning credit working with us. So there's this whole pool of people who are out there who can help. We need to find out how to make that connection, because it's I'm speaking from the patient and the family and the caregiver perspective. And when I show you this came in from iPro. You all know what iPro is, Quality Assurance for Medicare. But this is the kind of stuff that happens, okay? Option for short-term rehab never provided by the hospital. These are complaints that have happened or problems that have happened. This is coming from the beneficiary. Did not receive discharge planning when in the hospital. Now, some of this might be a little dated because things are changing quickly. Discharge with no instructions. Insurance pressure to discharge too soon. Did not involve caregiver in the discharge plan. Now, again, I'm going to say this was a couple years ago, so hopefully some of this has changed. A lot of seniors tell us this other one. They've been cared for by many physicians in the hospital, none of which was their primary, and they don't know. Who's a hospitalist, they ask us. What is this hospitalist we keep hearing about? Okay, so this is the kind of thing that people need help with, and navigators, whether they're volunteers or people in the hospital, can be helpful with. Sent home alone, was afraid and did not know what to do. All right, now this is about medication. We've probably seen this before. Too many medications to track. I like this one here. Hospital gave prescription for the same medication I was taking, but with a different name, and I took both. Okay, this is stuff that happens. This is real stuff, okay? Changed dosages after I purchased the medications at discharge. Insurance problems, we all know that. Here's the perspective of follow-up physician visits. Realized that more questions I should have asked in the hospital. Having to wait several weeks to get an appointment, did not have transportation. You know, a lot of what's being asked to be changed now is guarantee there's a 7 days an appointment after 7 days to prevent readmission. That's one of the things that's being pushed, right? Difficulty getting a live person on the phone. Confusion about which physicians to follow up with. Okay. This is the caregiver perception. Lack of time for health workers to talk to patient and caregiver. Assumption the caregiver knows everything and has no questions. Assumption that there is a caregiver at home. This is one we stress in the field of aging. The caregiver doesn't realize they're the caregiver.
Yeah.
Oh, it's my husband. Okay? They're going to get burnt out sometimes. So these are some of the issues. Now, you had this passed out to you, and it's not a good copy here, but this is a lot of what you heard about before. that are the same kinds of things that a person who's a volunteer would do. Again, we're doing non-medical things. That's what I wanted to stress here, you know. Mark?
5 minutes?
5 minutes? Oh, I'm going to be done before then.
Super.
Let me just be like Dr. Rhoda and be a storyteller now. This is a good story. Not a good one, but I think it illustrates the type of problems that we sometimes see. A gentleman called me up who was a friend of mine from church, and he'd been in the rehab unit for quite a while, and he knew that maybe I could help him because he knew I was involved with aging. And he said, I've been here for 4 or 5 months, and I want to go home. My wife lives alone up here off Delaware Avenue, all by herself, no car. She has to come up here and see me. And I don't know why I can't go home. Now, he'd had a procedure, a colonoscopy type, or not colonoscopy, an ostomy type procedure, and he also fell. So he had to repair for both of those things, but not such that he couldn't, you know, return home. So he said to me, they gave me 3 choices. I've been here all this time. I can stay here and go into the nursing home wing and pay for that. I said, well, how are you paying for where you are now? I've been paying out of pocket. A lot of money. That's one. I can go home. I can go to assisted living in Schenectady. I said, and then your wife's never going to see you again, you know. And he said, or the third one is I can go home with 24 hours of care, home care, because they want a safe discharge. So that's where someone, now I'm not a navigator per se, but I'm an advocate. And that's where the advocate, I said, this doesn't sound like it should be this way. His wife is there alone. Fortunately, they had friends and people helping her, drive her up there. So I managed to speak to the care coordinator or whatever at this particular facility. And, well, he's got to go home with 24 hours, or possibly we could think about 16. He's going to pay for that. So then she said to me, and maybe some of you are in this business, so I don't mean to be, I'm going to give you what the other side was, which was that, you know, this has to be a safe discharge, obviously. So once he's home, he can decide whether he wants 16. We just got to get him home. So she did decide 16. When you go home, you're going to have 16 hours. You're going to pay for that. And he admitted that he had to have somebody still help him change the ostomy because he hadn't mastered that. Well, that was a year ago in November. He's home now. He's been hospitalized once more for something else, but basically he's living at home with a couple hours of help a week. And his wife sees him in bed every night. And he has friends who pick up his groceries or to drive him. I see his wife sometimes in Hannaford and Delmar with somebody, you know, who's with them. But I'm just wanting to stress, this is the kind of thing that we need people, whether they're advocates, whether they're navigators, whether they're in the hospital, whether they're in the community, because the bottom line is his quality of life and his way of life was being disrupted. And I hate to say it, but sometimes we get caught. You made one of the nicest comments of the day. An outcome is different than an output. And we're unfortunately, and I've worked in government, I see too much data collection and not enough of the outcome. I think we're increasingly seeing a lot of data collection, and I know it's all necessary, but we have to keep the bottom line there as to the person. Okay, have a good weekend.
A couple more slides for you here, please. Thank you, Michael. That was awesome. Any closing remarks? We really don't have any ourselves, but again, if you're on the line, please verify your attendance here by checking with us. If you haven't signed the sign-in sheet, please do that. Kendall and I always end our presentations by saying, unfortunately, we don't go away. You know, here are our emails. We'd be glad to talk to you. I think Ben brought up some points, and others did too, around I look at this as a lot of dots out there, and DSRIP monies really should be going into connecting those dots and helping us all to work seamlessly to help individuals and families. So we come to work every day trying to do that, and hopefully we'll get some answers, you know, in the next few years with DSRIP. So we really appreciate your time today. A question there, or comment?
Question. At the beginning, you mentioned that need to sign into HealthStream to watch the 2 videos?
Yeah, that's a separate process, a separate set of trainings. We can send you a reminder link for that. We'll also send you the slide deck from today.
Yeah, you can follow up with us. And I just wanted to say thank you again for everybody for coming out today. I know it was tough to kind of do this so late in the afternoon on a Friday, so we appreciate it, and it's obvious based on everything that everybody had to say today, the hard work that's being done, that they're really trying to close and bridge those gaps with the health piece, the social services piece, the human services piece, and it's just amazing work. So on behalf of Benny and our PMO, thank you so much. Have a great weekend.